Hi everyone. Let's begin with the snapshot that is actually the most important part of pathology, that's images. Now it's all about the pink and blue, but we're going to add a lot of more colors to it. Now there's a way to approach this. Of course, you're not going to jump to images without understanding the basic theory. So my advice is that please first go through all the video lectures, and if not that, at least the RR, the rapid review, so that you have a holistic approach. And now when you come to images, it acts something like a rapid review for all of you, and you can flip through these pages. So how I'm going to approach it is going to be in 3 sections. We are going to talk about general path first, followed by systemic, followed by hematology and blood banking. It'll have the pink and blue and all the cells and all the tubes and instruments and vacutainers. And alongside every image, we are going to add 1 or 2 bullet points, which are PYQs and expected questions in the paper. So let's get going. Let's keep it very crisp, concise, and at the same time extremely high yielding. So welcome to the Image Fest. Let's start. The first image that we have is going to be that of the black and white, that is myelin figure. So you of course know for a fact that this happens to be the electron microscopy. If someone asks you that how did you identify this, because it has that round and round appearance that is known as the concentric lamellation. You can see that roundedness over here. Where do you see it? You see it in 2 injuries, that is reversible as well as irreversible injury. Please remember that it starts in reversible cell injury and it increases in irreversible. So it's seen in both. That's also a PYQ. But what is it made up of? It is made up of 2 things. So first, primarily it is made up of phospholipids if a question comes, and above that a little bit of calcium is also there. So both phospholipids and calcium, but primarily phospholipids. That is it about myelin figures, the first picture, which is a round and round concentric lamellations. The next part of the cell injury chapter that you have are going to be what are the different nuclear changes. How does the nucleus break, whether it is in a case of apoptosis or necrosis? How is the nucleus breaking? So first and foremost, you have to remember the mnemonic PKK, that is pycnosis, karyorrhexis and karyolysis. So what happens in pycnosis? You can see, compare it with normal, the nucleus has become very, very shrunken. So that is what is referred to as pycnosis. The nucleus has become condensed. Next, going to karyorrhexis, you can see the nucleus has finally started to break. So that is nuclear fragmentation. And finally, you will see the nucleus has vanished. So that is karyolysis. And that means the nucleus has lysed. That is why I called it the famous PKK, pycnosis, karyorrhexis and karyolysis. Moving on to the next picture, we are going to start with the different types of necrosis, and we start with the most common necrosis, that is coagulative necrosis. We can see that there's a solid organ shown. So yes, this is seen in solid organs and their tissue architecture is very much going to be intact. Their tissue architecture is preserved. So what all solid organs? Like over here, you are seeing the section of a kidney, but other than that, it can be heart, it can be liver, and I hope you remember from your rapid review and videos that heart is going to be the most common organ affected. The same thing when you look under the microscope, you will see that there are going to be a lot of cells which are just outlines, pink color outlines. Nothing inside, just outlines like a ghost. So what do you call all these outlines? They are all ghost cells. So many ghosts. This has become a graveyard. So many ghosts and dead bodies means graveyard. So first and foremost, these are all the ghost cells. And secondly, this appearance is the tombstone. Why tombstone? Because it's a graveyard of tombstone. So these 2 points are very important for coagulative necrosis, because here the tissue architecture is preserved. It's the same solid organ, but that has died but still remains solid, right? Because now I'm going to take you to liquefactive necrosis, where I'm also going to give it another name, that is colliquative necrosis, because that is going to help you identify something is going to happen that is going to make it liquefied. Something is going to become liquefied, and I can see that over here. So what is the first point? That the tissue architecture has not been preserved. Solid has changed to liquid. And what are the organs in which you're going to identify this? This is seen, what is above you, that is in brain. So it will be seen in a case of stroke. It can also be seen in pancreas, like a case of pancreatitis. Basically, all those organs in which there is high enzymatic activity. High enzyme activity like brain, pancreas, they tend to become liquefied, known as, either you call it liquefactive or you call it colliquative. Liquid word aana chahiye. Moving on to the third one, if you're staying in India, it's obvious that you know this one. Caseous necrosis. What is the meaning of the word caseous? Caseous refers to cheese-like. Caseous refers to cheese-like appearance, and you can see that whitish cheese in front of you. What is this a combination of? This is actually a combination of coagulative and liquefactive necrosis, but more of coagulative necrosis. Where is it seen? No points for guessing the first one, that is TB. But other than TB, guys, this is also seen in fungal infections like histoplasmosis. This is also seen in other fungal infections like coccidioidomycosis. This can also be seen in syphilis. So definitely this is not only TB, it can be seen in a lot of other conditions also. This cheesiness is important for caseous necrosis. Moving on to the next one, which requires no introduction. The name itself is its introduction, fat necrosis. So you will see yellow color fat that you're seeing, and necrosis means death. So how do I identify that fat has died? Whenever I will see chalky white areas, can you all see these chalky white areas here and here and here and here? What are these chalky white areas? They are made up of calcium. So whenever you see chalky white areas, you know, okay, that fat has died. And where do you see it? In all the fatty organs. For example, breast has a lot of fat, omentum has a lot of fat. So all the fatty organs are definitely going to show you this. Why would breast show you? Whenever there is a case of trauma. Why will omentum show you? Whenever there is a case of acute pancreatitis. I hope you remember their entire pathogenesis and how in the end calcium is getting deposited. Now coming to the next one, fibrinoid necrosis. Firstly, what organ has been shown over here? This is red blood cell. Lumen में red blood cell means this is a blood vessel. And in the blood vessel, I'm seeing this pink color band, and that pink color band is fibrinoid necrosis. It is seen in all the three-letter things. For example, it is seen in, this is PAN, polyarthritis nodosa. It is seen in RHD, rheumatic heart disease, ash of bodies. SLE and HTN, that is hypertension. Which hypertension? Malignant hypertension. So repeating all the three-letter things show you fibrinoid necrosis. Coming on to the next one, which is not a pathology term. You'd study this a lot in surgery, but I thought it's important we study it over here. The different types of gangrene. Of course, gangrene, you know for a fact, is going to be very, very foul smelling. Once you see a case of gangrene, you'll remember it for a lifetime. And you know that the color is going to be a blackish discoloration. So now you can see the first picture shown to you over here is very dry, and that is referred to as what? That is dry gangrene, right? Because there is a proper line of demarcation that I'm seeing. Whereas what you see on the other end is going to be the famous wet gangrene. There is no line of demarcation seen. ये तो surgery term है. Dry and wet are surgery terms. What does it mean for the pathologist? Dry gangrene for the pathologist is coagulative necrosis. Wet gangrene is going to be liquefactive necrosis. So if I have to give you a 30-second recap, can we do that? Of course we can. This is your 30-second recap. Look at this. Solid organs, coagulative necrosis with all those ghost cells and tombstone, coagulative. But things start getting liquefied in brain and pancreas, liquefactive. When things start looking cheesy, that is caseous necrosis, especially TB in our country. When you see all yellow fat, of course fat necrosis. How do you identify? All chalky white calcium areas. When you start seeing a blood vessel with this pink band, this might be a case of PAN, polyarthritis nodosa, three-letter things, fibrinoid necrosis. Then you have dry gangrene and wet gangrene. Dry gangrene is the same as coagulative necrosis. Wet gangrene is the same as liquefactive necrosis. That is your 30-second recap of images of necrosis. Let's move on to the next. Of course, you know I'm going to talk about apoptosis. How do you identify an apoptotic body? So if I ask you, give me an example of apoptotic body that you see in a case of viral hepatitis. You all know that famous body called Councilman bodies. Okay, if I ask you one more question, a similar apoptotic body, example number 2, similar apoptotic body that you see in the skin, that is lichen planus. So there's a C wala body known as the colloid body. Colloid, also known as civet body, also known as cytoid body. All of these CC names are the same. So these two questions you get in the paper. What is Councilman body? ये भी C wala body है that you see in the liver, viral hepatitis. And this is a colloid, civet or cytoid body that is seen in lichen planus. Now moving on, we come to what exactly does it look like. So look at the cell. It's become a little chota. So what do you call it? There is cellular shrinkage. The size is going to shrink a little. But look at the colors. The colors are going to become very, very intense. The cytoplasm is going to look very, very pink, whereas the nucleus is going to look very, very blue. Why is this? Look at this. The cytoplasm is looking very, very pink and the nucleus is looking very, very blue. Why? Because here comes the hallmark. What is the hallmark of apoptosis? NCC, nuclear chromatin condensation, is the hallmark of apoptosis. Everyone remembers this? Very important point. Okay? So now if you look at the same picture over here, can you see these black and white photo? Matlab this must be electron microscope, and I can definitely see some black area in the periphery, and that is all the nucleus chromatin that has condensed. So always remember NCC as the hallmark of apoptosis. Now the same necrosis and apoptosis, if I want to see on a DNA electrophoresis, you have three patients in front of you, patient A, patient B and patient C. So patient A is totally normal because this DNA is totally intact. In B and C, I can see DNA is breaking. See, here also DNA has broken. Here also DNA has broken all the way. But what's the difference? In patient B, I see the very famous step ladder pattern. Step ladder pattern is seen where, guys, most commonly seen in apoptosis, but can it also be seen in necrosis? Yes, answer is both. But of course, the most common thing will always be apoptosis. On the other hand, the next one is as if smear, ink smear ho gaya, or blood has been smeared. It's like that kind of a thing. So DNA has been smeared over here, and that is known as smearing pattern. And smearing pattern is more famous. I'm not saying it's not seen in apoptosis again, but what is it more famous for? It is more famous for necrosis. Remember, one word pucha, so step ladder for apoptosis, smearing for necrosis. And I hope you all remember, step ladder pattern is a million times repeat PYQ. Let's move on to the next. We are done with the cell deaths. Now we need to know all the pigments. So the first pigment that I've got for all of you is the skin pigment, and that is melanin. Melanin is where? Melanin is in the skin. Of course, as I just told you, skin, hair, eyes, that has melanin. So I've got you a skin section. If you want, we can zoom in. Can you all appreciate that there is a brown color pigment over here, hai na? So this brown color pigment that I'm talking about is melanin. And where is it present? If I ask you a question, the brown black pigment in the skin is present in which layer? You could see it was at the bottommost layer of the epidermis, means it is present in stratum basalis. Or in other words, stratum basal shows you, basal layer shows you melanin. It's a dermatology question. I want to confirm it, guys. What is your mnemonic? M for M. Melanin ke liye kya hai? M for M, Mason Fontana. So the next picture that you see over here, you could see now there are so many Masons, Mason trichrome and so many. How will I know Mason Fontana? Because tanning of the skin is by melanin, hai na? So melanin ka this black color that has come with Mason Fontana stain. And then I can see one bluish color stain. This bluish color stain is the Schmold stain. What did I say? Schmold stain, because again, mole will also remind me of melanin only. Finally, if they ask you two questions, can you fill in the blank? Which is the best enzyme for melanin? Which is the best immunohistochemistry for melanin? The best enzymatic method is going to be dopa oxidase. No pictures needed, right? And the best immunohistochemical method is going to be HMB45. So repeating, dopa oxidase is enzyme. So that's the best enzyme. And HMB45 is the best immunohistochemistry. Melanin done. Moving on to the next pigment, and that is hemosiderin. The word only tells you that hemo, this is going to be seen in all hematoma, hemorrhage and those kind of conditions. So what is the stain? The stain is known by the word sidro. Anything that I want to stain for sidro means iron is going to be the famous pearl stain or Prussian blue. And if you look at the picture over here, you can very well appreciate that there are all blue colors. So anything to do with iron comes, iron overload, hemochromatosis, any iron overload condition comes, and your answer is pearl stain. So hemosiderin had iron, answer is pearl stain, other name Prussian blue. Blue will tell me that I've got a blue color. Sorted? Moving on to the next one, examiner's favorite, FMG NEET INI CET, evergreen question, that is lipofuscin. So first and foremost, what are its other names? It is known as the very famous, the wear and tear pigment. As you get old, you have more and more wear and tear. As you get old, you have more and more free radical injury. So this is a pigment which is indicative of age, indicative of injury, indicative of wear and tear. Old age ka pigment hai. So I tend to call it the senile pigment. It is a senile atrophy. And let me look at the color. If you zoom into this picture, you can definitely see that this pigment has got a brownish color to it. So what else can I call it? I can call it brown atrophy. So remember, wear and tear, free radical injury, old age pigment, brown atrophy. Usually what is that old age? Usually we get an 83-year-old patient. As I say, we never know the reason of why 83 is their favorite age in the exam, but it is. Okay, on that note, what is the location? If you notice carefully, it is perinuclear. That is why I got you a picture over here also, where you can appreciate that if this blue color thing is the nucleus, This is perinuclear. Always it is around the nucleus, है ना? And same thing you got to see on an electron microscope, this black color thing around the nucleus. So perinuclear word, an 83-year-old word you have to know. What are the stains? Guys, first you pick up the word lipo. Lipo will remind you of everything to do with fat. So one stain is going to be oil red O. And fustian will remind you of everything to do with fast. So fast stain is the Zn stain. Oil red O and Zn stain are the two stains that you have. Now we've done all the pigments. One pigment doesn't have a picture, but it has a movie picture. And what is that? I hope you remember that what are the stains for copper? RRR, that movie that we studied. So copper ends with an R and the name of the stains begin with an R. R for rhodanine and R for rubianic acid. So copper, R, rhodanine, rubianic acid. There are no images, but I just wanted to revise it once. Let's move on to lipid accumulation. Pigments are done. When lipid, now this I've got from surgery, medicine, everywhere. Where all can fat accumulate? If what is this? Greenish color, matlab it must be gallbladder. There is yellow lipid. I hope everyone can appreciate. There is yellow lipid that you're seeing in the gallbladder. What is this known as? Cholesterolosis gallbladder. And has it started looking like strawberry? Yes. So strawberry gallbladder is nothing but lipid, cholesterol in the gallbladder. Okay, one image is done. Where else can lipid accumulate, guys? This is from a blood vessel. So, coronary artery, fat accumulating. What is the name of that disease? That is known as atherosclerosis. So, atherosclerosis shows you these white areas. You will say, why is this white? Because basically this was all fat or lipid and that lipid got washed off. That lipid got removed. So this is in the memory of lipid, you're seeing these white areas. These are known as clefts, cholesterol clefts. So remember, cholesterolosis, gallbladder, strawberry gallbladder is lipid. Cholesterol clefts in atherosclerosis, that is lipid. So now you will ask me, what are the stains for lipid? Very simple, no rocket science. Red color ka lipid dikhaya, what will you name it? You will obviously call it oil red O. No rocket science. If you see black color ka lipid, you will always call it Sudan black B. Again, no rocket science. Red hai to red, black hai to black. But then this orange color is a little bit of rocket science because here it is Sudan 4. Sudan 4, and let me tell you one more stain on which you don't get a picture but again can come in the paper, osmium tetraoxide. So repeating 4 stains, oil red O, Sudan black B, Sudan 4 and osmium tetraoxide. These are going to be the stains for lipid. Now let's move forward. There is a machine called cryostat. So please remember, cryostat has 2 uses. Firstly, break the word cryostat. Cryo will tell you that the temperature inside this machine is going to be minus. It's like minus 20, minus 25 degree. And stat word is going to tell you that something is going to happen stat. We are going to get a stat diagnosis. When do you need a stat diagnosis? When the gynecologist or surgeon has sent a frozen section. Frozen section means you want the diagnosis in 15 minutes. This is the machine you will put your tissue in. Secondly, when you have to use a lipid stain oil red O, you can also use this machine, and that is a previous year JIPMER exam question. So repeating, guys, cryostat has 2 uses. Cryo means frozen temperatures and it is used for frozen section. And second, whenever you have to do lipid staining with oil red O. Done. Let's move on to everyone's favorite, calcium. What is this round and round onion skin body? This round and round body is known as the Samoma body. But what kind of calcium is my question? This is a kind of dystrophic calcification. Very, very important. So where do you see it? Do you remember the mnemonic PSM square? When I'm talking about Samoma body, PSM square. So the first P that I'm talking about is papillary carcinoma. Guys, now that papillary carcinoma, if you ask me, everywhere of the body, thyroid cancer or papillary carcinoma, endometrium, ovary, intestine, lungs, kidney, any papillary carcinoma. The next P is going to be the famous prolactinoma. So PPSSMM, okay, PSM square. So papillary carcinoma, prolactinoma. The next is going to be somatostatinoma, serous ovarian tumors, mesothelioma and meningioma. That is your PSM square. So repeating, papillary, prolactinoma, somatostatinoma and serous ovarian tumors, mesothelioma and meningioma. Very important, all of them show you the same Samoma bodies. Let's move forward. Because you said this is a kind of calcification, I'm going to tell you stains for calcium. If you remember your mnemonic, calcium had to be learnt by the mnemonic calcium. So first, calcium sounds like calcine, jiska you don't get a picture. You just have to know, yeah, that is one stain. Calcium sounds like K wala sound. So the first stain that you have a picture over here is von Cossa. And I hope everyone can appreciate over here, Cossa has got a kala color. That is how we had learned. Kosa is going to be kala, right? So yes, here what you have is Kosa is black. So very beautifully you can see that color. Next you have a red color stain. So obviously that is alizarin red S, and that is how you had learned with the AL alphabets. You had learned alizarin red S. So repeating, calcium, calcine, calcium, Kosa, AL, alizarin red S, and which of them is used for staining minute amounts of calcium? So if you remember, alizarin red S was for zara sa calcium. Zara sa calcium means minute amount of calcium. So do you want to do a 30-second recap of whatever we have studied up till now? Is that possible to do it in 30 seconds? I think it is. Firstly, whenever you're talking about melanin, melanin shows you that stratum basal. So that black color is Mason Fontana, and then you can also have a small stain for it. If there's a history of hemorrhage or hematoma, which pigment? Hemosiderin iron, so Prussian blue. When you're talking about all fatty things, red color wala oil red O, black wala Sudan black B, and orange one is going to be Sudan 4. Next, you're talking about the old age pigment, the pigment that is going to be an 83-year-old man with perinuclear location, lipofuscin, very famous, wear and tear pigment. Now talking about calcium, the round and round body is Samoma body, the stains, the kala color is Wand Kosa, and red color is alizarin red S. That is your 30-second review of all the things that you studied till now. Let's move on to the next part, and let's now study something which is known as a part of the next chapter. Cell injury chapter done. Let's begin with the images of the next chapter, and that is inflammation. The first one that you see in front of you is NETs, that is neutrophil extracellular traps. Let's repeat. So I'm going to have a neutrophil, which I can very well see over here. And something is going to happen outside, extracellular traps. So why am I making extracellular traps over here? Because I want to kill some bacteria, virus, parasite. This is going to happen in cases of sepsis. So this is a kind of a killing which is seen in sepsis. Now, how did this happen? If you can see, the neutrophil has sent all of its nuclear chromatin outside. So what has been sent outside? The nuclear chromatin has been sent extracellularly, and who is going to help in this release? Remember, we need arginine. Arginine is needed for this entire process to occur. So imagine all of the neutrophil nucleus, all of the nucleus is going outside. This means that this is going to result in death of the cell. This condition is also known as a beneficial suicide. So yes, we are killing the bacteria virus, but the cell is also committing suicide in that process. What can it lead to? Now, because all the nuclear antigens are going to be exposed, it can result in the formation of anti-nuclear antibodies, which means, which is the disease which shows you anti-nuclear antibodies? SLE. So these are the questions. What is neutrophil extracellular traps? Question 1, it's a kind of killing. Do you see it intracellularly or extracellularly? Outside, okay. And who is going to allow this to happen? It is arginine. Because what is the side effect of it? What can happen because of it? It is going to be SLE. What is the other name for it? It is also known as beneficial suicide. There's another picture for neutrophil extracellular traps where they'll give you two images. In the first one, you can definitely see that the green color one is the cytoplasm, and the orange color one that you see over here is the nucleus, right? So this is going to be a normal cell. And look at the next one, all the orange color has come out. All the orange color has basically come out. This means the nucleus has come out. Neutrophil extracellular traps has happened. So one word, nucleus will come out. Moving on to the next. What is cell in cell? Previous year question. Cell in cell is known as emperipolesis. There is a big cell and that has eaten a small cell, but no one's going to kill, harmless. This is not going to be killing. It's just like, keeping the food in your mouth, but after that spitting it out. You're not chewing it, you're not digesting it. Keeping the food in your mouth and spitting it out. That is cell in cell. That is known as emperipolesis. And where is it seen? It is seen in mark, which means M stands for myelodysplastic syndrome and myeloproliferative neoplasms. A stands for autoimmune hepatitis. R stands for Rosai-Dorfman disease. I hope you all remember, I have taught you this in the main course videos. Rosai-Dorfman disease. And C stands for CLL. So all three-letter things, MDS, MPN, autoimmune hepatitis, Rosai-Dorfman and CLL. These are the things that are going to show you cell in cell, emperipolesis. Moving on to the next. Although you have a lot of diseases that happen in inflammation chapter, this is one disease which gets you image-based questions. And that is Shediac-Higashi syndrome. So firstly, what is the defect that you see in Shediac-Higashi syndrome? It is a lysosomal defect. It is a list gene lysosome that is going to be a problem. And the mnemonic for Shediac was Shediac. Quickly tell me, what did C stand for? C was standing for CNS problems. HE was standing for all hemorrhage and bleeding related problems. DI was standing for decreased immunity, means lots and lots of infections. A was standing for albinism. If you remember, this child had, you can see the hair. This child has silvery gray hair. So that's going to be one picture that will be given to you. And K was standing, look at the granules. We can see some huge granules. Coarse neutrophilic granules. The neutrophil is showing you coarse granules in the cytoplasm. That is the K that you have. So A and K of Shediac are going to show you albinism. You can see the silvery gray hair, and you can also see these coarse granules, lysosomal problem. Yes, all of the others were theoretical questions. I've covered those under the rapid review also. Let's move on to chronic inflammation now. We all know that a type of chronic inflammation is granuloma. So granuloma mein what is the most important? How did I pick this up? Most important cell of a granuloma, guys, is a PYQ, and that is known as epithelioid cell. Firstly, what is an epithelioid cell? It is nothing but a macrophage. It is nothing but a modified macrophage. So what is the modification in it? If I zoom in, the modification is that it has become elongated like a slipper. It has become elongated like a slipper over here. So it is nothing but a slipper shaped cell. All these long cells are epithelioid cells. Sorted? All these long cells, repeating, they are slipper nuclei. Slipper nuclei, very important. Apart from that, can you all notice the peripheries, guys? Blue color dot. Those blue color dot are lymphocytes. Yes, there are lymphocytes present, and you know which lymphocytes are these? These are T helper 1, matlab CD4. Why? Because T helper 1 cells release interferon gamma, and I know G for gamma, G for granuloma. They ask you which is the interferon responsible for granuloma formation. So you will say, oh, TH1 cells honge because they release gamma, and gamma is responsible for granuloma formation. Okay, so epithelioid cells, most important cell I have seen. Second, I've shown you which is the lymphocytic collar. Now let me ask you a theoretical question. I had taught you that if this lymphocytic collar is absent, what disease is it? It is sarcoidosis. Lymphocytic collar absent means collar, clothing is not there. The granuloma is naked. It is a naked granuloma. And which condition shows you naked granuloma? It is sarcoidosis. Very important point. Now let me tell you that the other thing which is going to be present in all the granulomas will be giant cells. Should we quickly revise all the giant cells? The first one that we have in front of us is the Langerhans giant cell. We all know Langerhans, not Langerhans. Hai na? This you remember, Langerhans giant cell nahi hota. Langerhans is an antigen presenting cell present in the skin. Here it's a Langerhans giant cell, and that is what shows you the famous horseshoe shaped nuclei. You can see that. The nuclei are arranged in a horseshoe manner, and which condition shows this? This is seen in case of tuberculosis. Moving on to the next one. If you see the nuclei over here, they are all round, matlab wreath-like. This is the Teuton giant cell. Wreath-like nuclei, and if you see the cytoplasm, round, wreath-like nucleus, to theek hai. But cytoplasm is a little whitish, vacuolated. Why? Because it has fat. Vacuolated cytoplasm is there because it has fat. And this, what is it seen in? All fatty things. Xanthoma. Xanthoma means it's seen in all the fat-related disorder. That is Teuton giant cell. Moving on to the third one, foreign body giant cell. Of course, this is seen with some kind of foreign body. It could be some suture material, it could be some talcum powder, some kind of foreign body. And how do I identify it? It's got all haphazard, idhar udhar, all scattered kind of nuclei that I can see over here. So some foreign body element like suture, talcum powder ka history will be given. Now moving on to the examiner's favorite, the Worden-Finkelde giant cell. So W, and you make the opposite of W, that's going to be M. So this is seen in cases of measles. And how do I identify it? Measles virus is very famous for having both intranuclear and intracytoplasmic inclusion. So when I zoom into this giant cell, I will be able to see that there are dots in the nucleus. Everyone, can you see the pink color dots in the nucleus? And other than that, there are tiny pink color dots in the cytoplasm also. So it has both intranuclear and intracytoplasmic inclusions. That is very, very famous for measles. Please note which are the only two viruses that you study in virology where intranuclear and intracytoplasmic inclusions are seen. One is measles and the other is the famous cytomegalovirus, the owli, that I'm going to show you in a while. Everyone's okay with Worden? W ka ulta, Worden ka ulta, measles. Coming on to what you were talking about, owli, but this owli is a different one. What am I showing you? Reed-Sternberg cell. RS cell is seen in which lymphoma? The very famous Hodgkin's lymphoma. So please note, what kind of nuclei does it have? It has two identical nuclei, mirror image nuclei, and these are said to have, can you see these eyes? That is why you call them owl eye. But what color eyes? These are pink color eyes, and that is what they ask you in the paper. Which other condition shows you owl eye appearance? These two owl eyes. See, I've got two eyes, one pink wala eyes, one blue wala eyes. So pink wala eyes is known as the Reed-Sternberg cells. Reed and Sternberg, girls ka naam hai, female scientists. So Reed and Sternberg means that somewhere over here I have pink color eyes. I hope you can all appreciate these pink color eyes. Whereas when I'm talking about cytomegalovirus is a mega man. Mega man means man ka favorite color blue. So what are the eyes going to be? The eyes are going to be blue in color. So please remember, that is how you differentiate the two eyes. The pink color eyes are girls ka color, Reed and Sternberg ka color, pink eyes. And cytomegalo, megalo man, so big man, his favorite color, blue eyes. Let's move on to the last giant cell, which is again something from micro known as herpes virus. And herpes virus ka giant cell is identified by MMM. What are the three M's, guys? Please note, it is multinucleation, molding and margination. Multinucleation, can you all see that multinucleation? Can you see there are lots of nuclei? I can count 1, 2, 3, 4, 5, 6, 7, at least I could count multinucleation. Second, they are all stuck to each other, molding, they are changing each other's shape. The molding also understood. What is margination? The margins are very, very dark blue in color. So multinucleation, molding and margination, when these three M's are written, I'm gonna think of herpes virus. So now if I tell you quickly, you could see the Langhans giant cell where Langhans giant cell was seen in TB, it had the horseshoe shape arrangement. Touton giant cell was seen in xanthoma, it had the round wreath-like arrangement. Foreign body, of course, seen with foreign body, all haphazard arrangement. W ka ulta Warthin was seen in measles, and it had what? How did you identify? Intranuclear and intracytoplasmic inclusion. Reed-Sternberg cell was the very famous owl eye with pink color eyes, and herpes simplex or herpes virus was the triple M, that is multinucleation, molding and margination. That is your 30-second recap of all the giant cells. Now, coming to different granulomas. Do you guys remember what was this? The one that was looking like a star. The star shape is stellate granuloma, and where do you see it? Number one, it is seen in cat scratch disease, and the second condition is known as lymphogranuloma venereum. So it's seen in both. Watch out for both, because many times both the options are given. So remember, this stellate granuloma is seen in cat scratch and LGV. Next, we come to the donut. It looks like a donut. There's no doubt about it. It looks like a donut, but they might want to ask you what is the other name. It is also known as a fibrin ring granuloma. It means the same. Ring, donut means the same, okay? And where is it seen in? So from your donut, you're going to make a line like this because it is seen in Q fever. And it is also seen with a drug that is known as allopurinol. So these two questions have come in the previous year papers. Coming to the last granuloma that you have, where you can see two granulomas which are something like this. Can you all see two parallel lines? And what are these parallel lines? They have dot 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 inside it. This is the dot 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 wala Dirk granuloma, which you see with Plasmodium falciparum. Plasmodium falciparum means which malaria? Cerebral malaria. And when I'm talking about cerebral malaria, I know from microbiology that for falciparum, I have a special stain called field stain, FNF. Falciparum ke liye, see this special blue color stain, the field stain. And now you'll ask me, what are all these dot 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 that you were showing me, ma'am? That was Plasmodium falciparum. Those are rings of Plasmodium falciparum. So Dirk granuloma is seen in Dimag wala malaria, okay? Dirk granuloma is going to be seen in Dimag wala malaria, cerebral malaria, which you know is Plasmodium falciparum, and F for F, field stain is there. All the granulomas are done very commonly. Granuloma word is confused with something called granulation tissue, and they're totally different. Granuloma, to you've understood, na? Jaise TB ka, malaria ka, Q fever. Granuloma is different. I'm talking about granulation tissue because granulation tissue is the hallmark of wound healing, of repair. When a person gets hurt, that is what is granulation tissue. This does not have all those giant cells and all. What does this have? When we are healing or repairing, we need a lot of blood vessels. So number one, this has lots and lots and lots of blood vessels, plus. Okay? Apart from that, it has a little bit of inflammatory cells and it has a little bit of fibroblasts also. Okay? These are there, but the identification point is going to be these lots of blood vessels. That is a granulation tissue, so no points for guessing. What is the color of granulation tissue? Of course, it's going to be extremely red. Okay, so now this was about healing, but what if someone ends up having too much of healing? What is that in surgery known as? Too much of healing is known to be keloid and hypertrophic scars. So let's do differences between keloid versus hypertrophic scars. So let me tell you, keloid is everything, too much. Too much is everything. Everything will be in excess. Hypertrophic scar is little sober. That's how I have learned it. So if I ask you in a keloid, how will you see like piercing to happened over here, one dot, but the keloid has crossed. It is so huge. Keloid on the sternum is also huge. So it crosses the wound margin. It's too aggressive. Whereas hypertrophic scar, if the incision was here, hypertrophic scar is within, thoda sa sober hai, right? So keloid crosses the wound margin, hypertrophic scar is within the wound margin. They ask you what is the most common site of keloid that has been shown in front of you, that is the sternum. And they ask you what is the treatment of keloid, you have to give an injection. You have to give what injection? Injection within the lesion. There's an injection which is intralesional. And what injection? It's a steroid. What is the name of the drug? Triamcinolone. So triamcinolone, you basically inject it over here and the keloid is going to shrink. If you wanted to see keloid and hypertrophic scar under the microscope, what stain will you use? You will use Mason trichrome, not Mason Fontana. Mason Fontana was for melanin, na? Mason trichrome, tricolor, 3 colors is what you're gonna see. So guys, what are the 3 colors? Muscle, muscle is gonna get a red color. Collagen is going to get a blue color. So nucleus bhi hai, nucleus gets a blue-black color. I don't want you to learn nucleus. Nucleus is not important. What you have to learn is Mason trichrome helps me differentiate collagen versus muscle. One is red, one is blue. So I have learned mister. So muscle is red. And collagen over here and collagen over here is blue. So keloid and hypertrophic scar is collagen. So dono blue dikhega. But how did I differentiate them? So if you can see this guys very clearly over here, you are getting too many haphazard big bundles. They are all left, right, upar, niche. They are all arranged in a very haphazard manner if you can appreciate them. So keloid is aggressive. Now keloid is going to be arranged in that haphazard thick bundles. Whereas hypertrophic scar is very sober. Hypertrophic scar has very thin, nice fibers arranged parallel to each other. So hypertrophic scar is going to have thin, orderly fibers. Simple. So keloid, clinically also keloid crosses the margins. Microscopically also keloid is going to be very haphazard. Clinically also hypertrophic scar is very orderly. Microscopically also it is very orderly. I hope everyone's understood this because inflammation chapter images are done for us. Let's begin with the images of the genetics chapter. The first image in front of you is of the Marfan syndrome. First, I want all of you to tell me how Marfan syndrome affects which chromosome. I hope you remember chromosome number 15 and the gene is FBN1. What is FBN? Means it is the problem in the fibrillin protein that is going to be happening over here. What is the most common abnormality? I hope you remember in your videos I've told you all the genetics and all the different clinical features of Marfan's, but overall what is the most common clinical abnormality is going to be the skeletal changes. So skeletal abnormalities are most common and I've got you the skeletal abnormalities in front of you. The first one that you have is extremely long fingers, which we call as spider fingers also, and that is known as arachnodactyly. The next one that we have are 2 signs that you get in medicine. Because their fingers are so long, their thumb is also very long. So if you tell them to close their fist, their thumb is going to come out from the side and that is known as the Steenberg sign. Please remember Steenberg has the T in it, so that is the thumb wala sign. Versus if you tell them to hold their wrist, they can hold their wrist between their thumb and their little finger. So the wrist wala sign is the W, that is Walker sign. So please note that when they'll ask you the thumb sign, you will say the Steenberg sign, and when they'll ask you the wrist sign, you will say the Walker sign. So overall, I realize all the skeletal abnormalities are the most common. Of course, you're going to get a question on what? You shall get a question on the lens abnormality. I hope all of you remember that what was the lens change that you see in Marfan. So I told you, of course, we know it is ectopia lentis or dislocation of the lens, but they ask you that that is occurring in which direction. So please note fan is going to be up, always up, na? So the lens is going to get dislocated up, that is supero, and fan will always throw the air outside. So the lens is also going to go outside. So this is a kind of an up and out. We call it up and out or superotemporal dislocation of the lens that is going to occur. And if I ask you one more question of ophthalmology, where do you see inferonasal dislocation? Ulta, in and down and in. So inferonasal. I and N is going to be seen in homocystinuria. It is seen in homocystinuria, that is inferonasal. Sorted? Let's move forward. Marfan syndrome done. Let's go on to the next condition, which is, and why did if I ask you in Marfan, what is the inheritance? The inheritance is autosomal dominant. So let me take you towards some autosomal recessive disorders. The autosomal recessive is enzyme deficiency, alkaptonuria. Which enzyme deficiency that you have over here? We have homogentisic acid oxidase. Homogentisic acid oxidase, HAO, is the enzyme deficient. As a result, homogentisic acid, black color, starts getting accumulated. So first and foremost, you see urine. Urine is going to be black in color, but I see patient comes to me with normal urine and that changes black to black on standing. So on exposure to air, it is going to become black. Next, where else does homogentisic acid go? It goes into the cartilage. So I can very well see that the ear and the nose, cartilage wala areas will become black. Then I can see over here that the nails are also becoming black. So the homogentisic acid also goes and deposits in the nails. This is what is called as alkaptonuria, and all of this is also referred to as ochronosis. This is going to be an autosomal recessive inheritance that you have to know. One more autosomal recessive inheritance. All the lysosomal storage enzymes, enzyme defects, all the lysosomal storage disorders, they are also autosomal recessive. So can you tell me Tay-Sachs disease? It is autosomal recessive. So what is the enzyme deficiency? So firstly, Tay-Sachs. Sachs sounds like 6. So there is a hexosaminidase deficiency. There is a hexosaminidase deficiency in alpha or beta. So again, Tay-Sachs has Tay, so many A's in it. So it is alpha hexosaminidase deficiency that is there. What are the different things that you're going to see? Firstly, over here, you can see the very, very famous balloon neuron. You're seeing such a big neuron over here. It's as if it's like a big water balloon. So if they ask you, what is this balloon neuron containing? Fat. That's why I've written it in red. It is oil red O positive. Previous year question. What else? I can see some onion skinning happening over here. Can we all appreciate these round and round black and white electron microscopic pictures? Onion skinning of what? Of course, lysosomal storage disorder hai, so it's onion skinning of lysosomes. And lastly, what is it that you see in ophthalmology? We can see that cherry red spot at the macula. So these are the 3 findings that you will see in Tay-Sachs disease: balloon neurons, onion skinning, and cherry red spot. Now, if I show you the next finding, what is this? Black and white stripes. Matlab they're looking like zebra bodies. Which lysosomal storage disorder is going to show you this? That is the Niemann-Pick disease. I hope you remember Niemann-Pick disease. If you go back to the main videos I have taught you, over here you are going to pick the spleen. You're going to pick the spleen. So splenomegaly is there, and that will remind you that SP, sphingomyelinase deficiency. There is going to be sphingomyelinase deficiency noted, and this pick the spleen was a NEET PG 2023 question. Apart from that, this is also seen in Fabry's disease. So this is not specific. Zebra bodies can be seen in a lot of conditions. But tell me, is there something about Fabry's disease which is very famous? Is there some appearance that you see? This is not important for FMG students, but very important for especially INI-CET. So wherever lipid is coming out into the urine, for example, in Fabry's disease, lipid comes out into the urine. Even in nephrotic syndrome, lipid comes out into the urine. Lipid in the urine can many a times show you this cross, Maltese cross appearance. Anything in microbiology that shows you Maltese cross appearance, please note this picture in front of you guys. I hope you know which organism shows you this cross, Babesia. So remember, these are all the Maltese cross. Whenever lipid will come into the urine, be it Fabry's or nephrotic syndrome, in microbio Babesia. And if you ever look at, you all know that gloves have powder. If you ever look at glove powder under the microscope, that can also show you this Maltese cross kind of pattern. Okay. Now, which lysosomal storage disorder are we left with? Examiners obsessed with this. There's been a hat trick and everything beyond that also in NEET PG for it. The very famous Gaucher's cell. Of course, I'm not asking you that this is seen in where? This is seen in Gaucher's disease. I shall definitely be asking you what is the enzyme deficiency. So G for G, this is seen in glucocerebrosidase deficiency. Glucocerebrosidase. In the exam, you will get confused between glucocerebrosidase or galactosidase. So remember, Gaucher's has U. So glucocerebrosidase, G and U dekhna, not galactocerebro, not galactosidase, glucocerebrosidase. And how did I pick up? What is this looking like? This cell that you have, it looks as if you've crushed a paper, as if what you want to do to your syllabus and your notes right now. As if you've crushed your syllabus and notes. So that is known as the very famous crumpled tissue paper appearance. Very, very important image. Let's move forward. We are done with all the lysosomal storage, and all of these were autosomal recessive mostly, right? I hope you remember all the lysosomal storage disorders are going to be autosomal recessive except two. What were the two? These were Fabry's and Hunter's. Fabry's and Hunter's were belonging to XLR group of inheritance. Yes? These are Mendelian disorders. What do you have to do in non-Mendelian disorders? Under non-Mendelian disorders, guys, we have something which is to do with mitochondrial diseases, and that mitochondrial inheritance is known as MRF. Now, what is MRF? You can see that the patient will have myoclonus, the patient will have epilepsy. Clinical features ho gaya. And microscopically, I will see RRF, red ragged fibers. Yes, I can see that red ragged fibers. Can you all appreciate that there are red fibers? These red ragged fibers are nothing but abnormal mitochondria. These red ragged fibers are nothing but abnormal mitochondria. Now, when you look at the same thing under the electron microscope, you can see something over here which is giving you that round and round appearance. That is known as the phonograph record appearance. It's looking like those old age phonograph records. And the same way, it looks as if cars are parked in some random order. So that is also known as the parking lot appearance. So overall, I realized that abnormal mitochondria are looking like these red ragged fibers. Abnormal mitochondria are looking like phonographs. Abnormal mitochondria are looking like parking lot. And patient is going to have myoclonus and epilepsy. So that is going to be MRF. This was about your mitochondrial inheritance. What is the image that you need to know, guys, about trinucleotide repeat disorders? Fragile X syndrome. Who will tell me which chromosome is involved in Fragile X syndrome? XQ, obviously, that's there. But what is the gene? Familial mental retardation 1 gene. FMR gene is going to be affected over here. That is why these patients actually have mental retardation. The question that has come in the paper is, what is their IQ? Their IQ is between 20 to 60. That's a PYQ. They have mental retardation because FMR gene is affected. And what is affected in it? CGG repeats have happened. So they give you an image of how this patient looks like. Many students learn it like PK wala face, Aamir Khan wala face. And what is that? Everything big, big, big. Sab kuch big hoga. Look at the face. Their face is going to be very, very long. Look at the jaw mandible, very, very long. Look at the ears, like PK, like Aamir Khan, very, very large. So long face, large mandible, big ears. But if they ask you what is the most characteristic feature, none of these. Most characteristic feature is large testes, means macroorchidism. Again, a previous year question. Macroorchidism, most characteristic feature. Sorted. This was which repeat? CGG repeats results in Fragile X syndrome. But if I change it, and if I ask you myotonic dystrophy, you will say now myotonic has a T in the center, dystrophy has a T in the center. So instead of CGG, I won't write CGG, I'll put a T in the center. The repeats are going to be CTG, and the chromosome has come so many times, it is going to be chromosome 19. And if you all remember, the way you write CTG, there's one very important clinical feature about myotonic dystrophy. Cannot terminate grip. If you tell them to hold on to something, they will hold on to it very tight and won't leave it. They cannot terminate the grip. They hold on and cling on to it. So CTG means cannot terminate grip. CTG also means what? C and T, Christmas tree cataract, and that is what you see above. You can very well see there is a Christmas tree cataract that you see over here. And look at the faces. This tends to show you a very sharp jawline. Everyone wants this, but not to that extent. But yeah, this is known as the hatchet faces that these patients have. So that is myotonic dystrophy, CTG, cannot terminate grip, and it is also going to be Christmas tree cataract. Let's move on to the chromosomal disorders. And what is that? It is first one. Of course, I'm not going to ask you which trisomy. Down syndrome trisomy 21. These are all the pictures from head to toe that a Down syndrome patient can show you. The first thing that you have over here is going to be, this child will always have an open mouth. Why will he have an open mouth? Because the tongue is coming out. The tongue is very big, macroglossia. Then look at his face. Why do we call it mongoloid faces? What is it about mongoloid? Look at their eyes. They will always have slanting eyes. So we can say they have oblique palpebral fissures. They have oblique eyes. And look at their nose. Their nose will always be flat. Why? Because the nasal bone has not developed. There is nasal bone hypoplasia that is going to be there. So simple, there are slanting eyes and flat nose. But if the ophthalmologist looks at the iris, what did I say? If the ophthalmologist looks at the iris, he will see these spots, and that is known as the brushfield spots. So head and neck, okay, open mouth with macroglossia, with mongoloid faces, flat nose and brushfield spots. What is in the hands? We all know there's one crease, there's just one single line that they have. and that is known as the simian crease. And look at the fifth digit. The fifth digit also has one line. So one line in the crease and only one line in the digit. And what is that one line in the hand known as? The simian crease. One line over here, simian crease. What do they have in their feet? It looks as if they are wearing a slipper, and that is referred to as the sandal toe. So please note, sandal pehna hai, that is why it's showing you that gap over here. So open mouth with mongoloid facies, flat nose, brush field spot, simian crease, sandal toe. That's your entire thing for Downs, trisomy 21. But if I now show you the next one, Pettau syndrome, guys, Patane ka age 13. So that is trisomy 13. And of course, what do you see? P for Pettau, P for polydactyly. P for Pettau, P for polydactyly. You see an extra digit. Again, P for Pettau, and P is going to be for cleft palate and cleft lip. Cleft palate and cleft lip. And finally, you can see that the eyes are having a keyhole deformity. Keyhole deformity in the eye is known as colobomas. So yes, that is going to make up the entire protocol for Pettau syndrome. Repeating, P for polydactyly, P for palate, and this keyhole, that is coloboma. I hope you remember from your theory, if someone, forget Pettau syndrome for a moment, if someone has multiple vertical colobomas, lots of keyholes in the eye, multiple vertical colobomas, which trisomy is that related to? That is associated with trisomy 22. I had learned tutu eyes. So tutu eyes mein lots of keyholes, lots of colobomas in tutu eyes. So that is going to be trisomy 22. Let's move forward. Patane ka age is 13. But what is Edward? E for Edward, E for 18. Trisomy 18 is Edward. And we have seen that the radiologist is going to give you the appearance of a strawberry skull in Edward syndrome. What is strawberry skull? Look at the back side. This back side over here. So this back side is very prominent and this chin is very, very small. So we basically learn it like a prominent occiput. The back side, that is the occiput. And the chin is very, very small. That gives the appearance of a, now if I draw it, that shall give the appearance of a strawberry skull. Apart from that, you can very well see that there are overlapping fingers and there are this kind of feet. What are they known as? Rocker bottom feet. Guys, let me tell you that rocker bottom feet are seen in both. Rocker bottom feet can be seen in trisomy 13, that is Pettau, trisomy 18 also, that is Edward. Dono mein dikhta hai. But Edward mein what is extra? The strawberry skull is going to be extra and the overlapping fingers is extra, right? Now if I ask you that what is, this was all extra. Now if I ask you, let's go into something missing. Something missing matlab monosomy. What is monosomy X? Monosomy X means one X is missing. Instead of two X chromosomes, there is a female which has one X chromosome. So out of this is the only one where the IQ is going to be normal, because from Downs to Pettau to Edward to everywhere there was mental retardation. Here the IQ is going to be normal. Okay, what else? This female is going to have number one, short stature, as you guys can see. Then the hairline, the posterior hairline is going to be very low posterior hairline. There's a fold of skin which is very important. I hope you all remember the fold of skin is known as a webbed neck. There is a webbing of the neck that is present. Anything else in the neck that is very important? These patients have a tumor in the neck called cystic hygroma. What exactly is a cystic hygroma? It is a lymphangioma that is present in the neck. What do you have in terms of their ovaries? I think everyone knows rudimentary ovaries. Rudimentary ovaries are known as streak ovaries. And because their ovaries are not developed, that is why they are never going to have menstruation. These are the basic points that you're going to have. So please note, webbing, cystic hygroma, these 2 points are very important. Short stature, IQ is normal, and they will never have menstruation because they are going to have streak ovaries. But you know, I've kept a final table to summarize it. In all these things that I've studied, one or the other cardiac problem happens. So please note that when you're dealing with Marfan's and Klinefelter, let me tell you, Marfan's and Klinefelter are two people who are very, very tall and their mitral valve has prolapsed. Remember, Marfan syndrome also has mitral valve prolapse and the patient is very tall. Klinefelter also has mitral valve prolapse and the patient is very tall. Coming to Downs, please remember Downs mate is endocardial cushion defect. These are all now recent questions which they will ask you. Endocardial cushion defect for Downs is most common. Pettau and Edward ka same hai, and that is patent ductus arteriosus. And for Turner syndrome, please remember many people believe coarctation of aorta, but before that what is important is bicuspid aortic valve. Bicuspid aortic valve more common, and then after that you can go in for coarctation of aorta. These are all the cardiac problems for these chromosomal disorders. Now let's move on to genetic diagnosis. How do you do the diagnosis? By the karyotyping. You can see a karyotype in front of you. Quickly answer these questions. If you get this image of these chromosomes, they're going to ask you how is it arranged. This is arranged in the decreasing order of length. So guys, maximum to minimum, you can see the longest is chromosome 1 and chota will keep on happening. So they ask you which is the shortest chromosome, and the shortest is 21. The shortest chromosome is going to be 21. So tell me, how do you do this? What are you going to do the arrest in? The arrest is going to occur in the metaphase. And how will you arrest the cells? The arrest is going to happen by a chemical known as colchicine. What is the fixative? There's a very famous fixative known as Carnoy fixative. Guys, Carnoy, C-A. So what all is there in Carnoy fixative? Before we come to the staining aspect, let me just tell you, C is the third alphabet, A is the first alphabet. So it is 3:1. 3:1 matlab it is going to have methanol and glacial acetic acid. Methanol to glacial acetic acid is C and A, 3:1. Now you will tell me what is the staining that has occurred in them. In all of them, the most common staining is known as G banding. G matlab, G stands for GIMSA. The most common banding is G banding. All of these are previous year questions. Metaphase, colchicine, fixative is 3:1, Carnoy is fixative, and the staining is GIMSA banding. GIMSA banding matlab normal light microscope. But if you want to do something fancy, if you say that I want to look at the chromosomes under fluorescent microscope, so fluorescent is something fancy, and who gets fancy stuff? The queen gets fancy stuff. So when you do Q banding, Q matlab queenacrine. तो queen के लिए fancy वाला microscope, G is गरीब, गरीब के लिए गरीब वाला microscope, that is going to be light microscope, ठीक है? Whereas queen के लिए fancy वाला microscope, that is fluorescent microscope. Now the same chromosomes you can see they're all fluorescent and shining. Let's move forward. Can you make the diagnosis over here? Very evident. I can see 3 chromosome 21, trisomy 21 has happened over here. This must be Down syndrome. Let's do one more diagnosis. Can you see what has happened over here? Come on guys. I see in the sex chromosomes there is XXY. There is a male patient and one more X chromosome. 47XXY basically means this is a case of Klinefelter syndrome. That is how karyotyping questions are going to come to you. The next genetic diagnosis that you have is going to be FISH. What is FISH? Fluorescence in situ hybridization. Please note, it is fluorescence in situ hybridization. So firstly, कुछ fluorescent use होगा. I can see some red and green fluorescent colors. Don't learn the colors. Examiner will give you. So fluorescence में examiner will say red color goes to 21, green color goes to chromosome 13. So देखो green color 13, 13. Everything is in pairs. 13, 13 chromosome is in pairs. ठीक है. But red color signals are 3. There are 321 chromosomes. What is your diagnosis? Guys, this is a case of trisomy 21, means this is a case of Down syndrome that you have. ठीक है. What phase is it done? So fluorescence, I have understood. I'll give some colors. I will tell me that this is done in interphase. This is done in interphase. Please note, karyotyping was being done in metaphase. Karyotyping was done in metaphase, whereas fluorescence in situ hybridization is done in interphase. What are the other uses of FISH? Have a look at this. If they say the red color is ABL gene and green color is BCR genes, okay. Red, pairs में ABL, green, BCR, ठीक है. But over here I see that the red and the green have fused. Red and the green have fused to form yellow. Over here also they have fused. Over here also they have fused. Basically, what are they telling me? They are telling me BCR and ABL का fusion हुआ है. And this fusion is nothing but Philadelphia chromosome. This is translocation 922. Translocation 922 is going to give me BCR-ABL fusion, and that is seen in a case of CML. So see, the same FISH can be useful in diagnosing translocations also, right? Another use of FISH is for knowing HER2/neu amplification. Firstly, where do you want to know HER2/neu amplification? Breast cancer. This is not important for FMG students. This image is only important for INI-CET aspirants. Please note that we have given HER2/neu gene ko they have given red color, and because HER2/neu gene is present on chromosome 17, so they have given a green color. अब बताओ, everyone has how many 17s? We always have pairs. तो green color हमेशा दो होगा. 1, 2, 1, 2, 1, 2. Green color is always gonna be 2. 17 chromosome is always 2. If there are 2 17 chromosomes, there should be 2 HER2/neu genes. बिल्कुल. Red color should also be 1, 2. Correct. So green color is also 2 and red color is also 2. ये तो normal है. But here I see lots of red color. HER2/neu is getting amplified. Here I see way too much of red color, HER2/neu is getting amplified. So they say that if HER2/neu upon CEP17 is more than 2.2, this means that there is amplification present. So patient के लिए क्या होगा? If amplification is present, what is the treatment that you will give? Guys, what is the treatment against HER2/neu amplification that you're going to give? Trastuzumab. Breast cancer में you're going to give trastuzumab if there is HER2 amplification. So do you want to count more than 2.2 matlab? You say, let's take this up, ma'am. How many HER2/neu, how many chromosome 17 signals are you seeing? 2 signals. So ठीक है, denominator हो गया 2. How many HER2 signals are you seeing? 1, 2, 3, 4, 5. Numerator हो गया 5. 2.5 is the HER2 upon CEP17. Anything above 2.2, matlab this patient has amplified. This patient has also amplified. So that is going to mean that I'm going to give these patients trastuzumab. Everyone's okay with breast cancer and HER2/neu? This is also done by FISH. Moving on to the next technique, everyone's favorite polymerase chain reaction, that is PCR, which comes to you as, they will not give you an image, but they'll give you the order. What are the 3 steps of polymerase chain reaction? The first thing is you have to separate the double-stranded DNA. From double-stranded, you have to make it single-stranded DNA. That is known as denaturation, and that is done at 94 degrees centigrade. After that, you're going to attach. Attachment matlab you're going to attach some primers, and that is known as annealing. Annealing is done at 54 degrees centigrade. And then you will make new DNA, you will extend, and extension is going to be done at 72 degrees. So they always ask you the pattern, and I think you all know DAE. DAE is going to be polymerase chain reaction. So PCR, DAE, that is denaturation, annealing, extension. You will have to put them in the correct sequence. I think you will be able to do it. PCR ho gaya, we move on to the next image, and that is CGH. What is CGH? Comparative genomic hybridization. It's typical red light, red, yellow, green, yaad rakho. Comparative, you are doing a comparison between your patient and a normal person. So to the normal person, you give a good green color. To the patient, you give an alert wala red color. Now, what will you do? You're going to hybridize your patient ka genes and patient and normal genes, you're going to hybridize. If you get a yellow color, means the patient is normal. Yellow color matlab normal. If you get a red color, red is at the top now, this means this person has a gain of function. Something is extra. This patient has some gain of function mutation. And if you get a green color, green is niche na, so there is going to be some loss of function mutation that is going to occur. So repeating, if there is too much of activity of genes, you will get a red color. If there is less of activity of genes, you will get a green color. So just like red light, बीच में येलो मतलब नॉर्मल, ऊपर वाला कलर रेड मतलब गेन, नीचे वाला कलर ग्रीन मतलब लॉस. So tell me, if I talk about this red color, what is this? Gain of function. Then what is this yellow color over here? This is normal. What is this green color over here? This is loss of function. I hope everyone will be able to analyze CGH, which we are done with. Now, the last thing in genetics that we need to know is about the very, very famous Loyens hypothesis. What does Loyens hypothesis tell me? Loyens hypothesis says that every female, 46XX, every female, one X chromosome is going to be active and the other X chromosome is going to be inactive. And that basically means that this inactive X chromosome is going to be either known as a, जो inactive वाला है, either you can call it a Barr body or you can call it a Davidson body. Let me tell you, Barr body, Davidson body, same thing, means composition. It is going to be the inactive X chromosome. So either you call it Barr body or you call it Davidson body. They just look different, but they mean the same. Look different matlab, Barr body is something that you will see in which sample? Buccal mucosa sample. When you take the buccal mucosa sample, you scrape the cheek. Can you see in the nucleus there is one blue color dot? Okay guys, this is the nucleus, and in the nucleus of this person you're seeing a blue color dot. This is the Barr body. So Barr body you will see in the buccal mucosa sample. Whereas what is Davidson? Davidson will remind you of D for D. Davidson looks like a drumstick. Davidson is going to look like a drumstick. Yes, you can see that drumstick appearance very, very nicely over here, but you see it in neutrophil, matlab blood sample. So remember, Barr body is something you see in buccal mucosa, whereas Davidson wala drumstick, you're going to see neutrophils in the blood sample. And I hope you remember, number of Barr bodies ka formula was equal to number of X chromosomes minus 1. So for example, female has how many X chromosomes? 2 X chromosomes. Matlab how many Barr bodies? 2 minus 1. One bar body. Every female has one bar body. One inactive X chromosome is present in every female. So remember this, that number of bar bodies are going to be number of X chromosomes minus 1. On that note, we have finished our discussion of the entire genetics related images. Moving on to the next chapter, and that is neoplasia, which has got too many tables that I've already discussed under RR and very few images. So we'll quickly wrap up the images out here. We've got clover leaf cells that you can see in front of you, these beautiful leaf-like cells. And what do you see it in? You see it with which infection? HTLV1. It's a virus, right? HTLV1, I hope you all remember, causes adult T-cell leukemia lymphomas via which gene? Via the TAX gene, and it shows you the beautiful leaf-like clover leaf cells, very famous spotter image. Because we are talking about viruses, why don't we talk about the others also? Where do you see koilocyte? Koilocyte is seen with human papilloma virus. How is a koilocyte going to look like? It's time for you to identify your favorite dry fruit, that is raisin. Raisin is kishmish. So if you look at the nucleus is going to look extremely shriveled and dark like this, like a raisin. So the nucleus is going to look like a raisin, so raisinoid nucleus. And around the nucleus, there is a perinuclear halo. You can see a white area around it. So there's a raisinoid nucleus with a perinuclear halo. Now let me make a table for all of you guys, because the same appearance, see, I'm not going to call it koilocyte. Yahi wala appearance with yahi wala name, that is the raisinoid nucleus with perinuclear halo, if I put it in a kidney cancer chromophobe RCC, the same appearance is seen in chromophobe RCC, but over there you call it plant cell. Let me tell you that if I write raisinoid nucleus with perinuclear halo because of a virus, you will call it koilocyte. If I write raisinoid nucleus with perinuclear halo in the kidney, you will call it chromophobe RCC ka plant cell. Same description, but two totally different things. Okay, so human papilloma virus, I hope you all remember the pathogenesis. It causes cervical cancer, penile cancer. How does it cause cancer? What are the two things that God has given it? God has given it E6 and E7. E6 is going to go and attack our policeman, that is P53 gene. E7 is going to go and attack our retinoblastoma gene. So these two genes are switched off. That is why patient ends up having cancer. This is a PYQ. How does HPV cause cancer? Next, they ask you, how does HPV cause koilocytosis? Koilocytosis is caused by E4 and E5 proteins. Koilocyte is caused by E4 and E5. And one last question. How is HPV vaccine prepared? This is a 3 times repeat in AIIMS. It is produced by the L1 region of HPV. So L1 region of HPV is going to be making the HPV vaccine. This virus is also done. Moving on to the next, the dancing virus, the virus which shows you this ballerina skirt appearance, just like a ballet dancer. So this virus with the ballerina skirt appearance is known as the Epstein-Barr virus. I hope you all remember. And the disease, of course, becomes infectious mononucleosis. So what is the name of this cell? This cell, you can't call it cell with ballerina skirt appearance. Cell ka naam kya hai? It is a Downey cell. And do you know what exactly is a Downey cell? Downey cell is a CD8 T cell. If they ask you what is the composition of Downey cell, it is a CD8 T cell. But twist in the story, if they ask you Epstein-Barr virus attacks which cell of our body, it attacks, देखो Epstein-Barr has B in it, na? So Epstein-Barr virus attacks B cell of our body. Via which receptor? Via CD21CR2. Epstein-Barr virus. This question has come 1 million times in the paper. Epstein-Barr virus enters into which cell of our body? B cell. What is the receptor through which it comes? CD21CR2. But after coming in our body, which is the cell which is going to save us or going to protect us? So the T cell says, wait, I'm going to make out that superhero wala cape, that ballerina skirt appearance, and I'm going to fly and save you. So this B cell is almost destroyed, very disturbed because EBV has entered, and T cell is the one which is going to come to its rescue. So T cell is the one which is going to be that superhero over here and make a ballerina skirt, and that is known as the Downey cell. The disease is, of course, infectious mononucleosis. If you ask me what is the test for this disease from microbiology, of course we all know the very famous Paul Bunnell test, but not done too much nowadays. What is the test which is done more commonly nowadays is going to be the monospot test. So the viruses are done. Let's move on to the next. This is a question that you get. What is this gun-like thing that you're seeing over here? This gun-like thing is a Franzen handle. F for F. Franzen handle is used for what? It is used for FNAC. I hope everyone will be able to identify this. FNAC matlab kya? FNAC is going to be fine needle aspiration cytology. FNAC stands for fine needle. You can see a fine, very thin needle, and aspiration because you can see a syringe. So I can see a needle and I can also see a syringe, and all of that is held with the help of a handle known as the Franzen handle. Let me show you some variations of FNAC. Number one, if I'm putting the needle, see for example, I'm putting the needle into the thyroid, but I'm also taking help of the ultrasound expert or a radiologist. What will I call it? Ultrasound guided FNAC. Okay? Second, if I'm using the FNAC, but can you see now there's no Franzen handle, there's no syringe. I have not used any syringe. What do you want to call it? That is non-aspiration cytology. I am not using any aspiration. If there is no syringe, I'm not using any aspiration. It is FNNAC, fine needle non-aspiration cytology. Okay? Now one question that comes in the paper. FNAC cannot differentiate which thyroid tumor. It cannot be used for the diagnosis of which thyroid tumor? Follicular thyroid cancer. Remember, you can never give the diagnosis of follicular thyroid cancer on FNAC. Very important question. Let's move forward. The next technique that is in front of you, the last picture of neoplasia, this brown color stain. Brown color stain is known as immunohistochemistry. What is the brown color because of? Brown color is because of DAB, diaminobenzidine, right? Whatever IHC you will get, you will always get a brown color. Now the question they will ask you is one or two very important ones. Cytokeratin, remember C for C. If cytokeratin IHC has come positive, you are thinking of carcinoma. It's carcinoma. If Vimentin has come positive, you are thinking of sarcoma. If LCA or CD45, LCA L for L, you are thinking of a lymphoma. And if HMB45 has come positive, you are thinking of a melanoma. Of course, there are many more IHCs which I will teach you in the course, but remember, cytokeratin carcinoma, Vimentin sarcoma, LCA is lymphoma, and HMB45 is going to be melanoma. Okay, so this is all brown color because of diaminobenzidine. Neoplasia ka images are done. We now move on to the immunity chapter images, and that is the first two rashes in front of you. First and foremost, you can see this butterfly shaped rash. This butterfly shaped rash is going to be known as the Malheur rash. And second, you can see a round wala rash, so round like a disc. So round like a disc is going to be discoid rash. Where are they seen? Of course, you know I'm talking about SLE. Guys, how many criteria did SLE have? SLE had 11 criteria. How many did you have to fulfill? You had to fulfill at least 4. So what was the mnemonic? MD Soap Brain. Do you want to do like a super rapid revision of MD Soap Brain? Try kare. So first, what is MD? MD means in front of you. Malheur rash, discoid rash. Okay. Then you have, because you're talking about skin, you have one more thing to do with skin, and that is photosensitivity. Okay. So Malheur rash, discoid rash, and photosensitivity are skin problems. Then what are inflammatory problems? Inflammatory problem mein itis, serositis, oral ulcers are also going to show inflammation, arthritis. So ye jitna bhi itis and inflammatory things hai, they have got together. Please note, these oral ulcers that you have over here are painless. These are painless oral ulcers that you have. So MD soap ho gaya, Malheur rash, discoid rash, and photosensitivity, serositis, arthritis, and oral ulcers. What are we left with? Brain. Brain is going to be all the organs. Firstly, tell me, what do you see? B for blood. Blood में एक बहुत famous cell है, that is Elie cell. Let me show you that cell, guys. That is also an image-based question. This picture over here is the picture of an Elie cell, and this is exactly how the question comes. What is an Elie cell? Of course, it is seen in SLE, no doubt about it. What is it? So some people say that it can either be a neutrophil or it can be a monocyte. These are the two possibilities. Either it's a neutrophil or it's a monocyte, and this big cell is a neutrophil or a monocyte, and it has eaten something. If you look carefully, it has eaten up a bluish color body here. Can everyone appreciate? One big blue body has been eaten. Blue color matlab hematoxylin. It has engulfed something known as hematoxylin body. So what is hematoxylin body? It is, see, SLE is what? It's an autoimmune disorder. Now we are going to break our things, we are going to damage our things. So hematoxylin body is nothing but a damaged nucleus. Some damaged cell or some damaged nucleus has been eaten up. So this is exactly how the question comes. What is it? It's either a neutrophil or a monocyte, and it has eaten up some damaged body known as hematoxylin body. That is the LE cell. That is what you see in the blood. What do you see? R for renal. Of course, SLE can involve the kidney. I've shown you images in the kidney part. What is the antibody? So I for immunological. We've done a list of all the antibodies under the rapid review, but which is the main immunology that you have? Anti-nuclear antibody. And finally, the N for nervous system. Patients can have psychosis, so that is MD SOAP brain. Of these ANA, they are definitely going to ask you, how are you going to do the diagnosis of ANA? And that is done by immunofluorescence. So these are different patterns, not just for SLE, probably for any kind of disorder. Pehle jaldi se identify these patterns, and method of identifying these patterns is by the mnemonic HAPPENS. So the H is going to be homogeneous, P is going to be peripheral or rim, N is going to be nucleolar, then speckled, and centromeric. That is happens. So I'll make you identify them one by one. Ye dekho guys, what is this? You will say the entire nucleus has become green. When everything has become green, this means this is the homogeneous pattern. This means antibodies are against everything. Antibodies are against chromatin, histone, double-stranded DNA, everything. The next one, only the periphery is going to be very, very green. So that is known as the peripheral or the rim pattern, and that is only and only for double-stranded DNA. Antibodies are against only. So we will learn it. How I have learned it is, instead of making the periphery like this, I have made the periphery like a DNA only, like a double-stranded DNA. I have made the periphery. So this is against dsDNA. Happens N now means that you're going to have just one N wala dot, that is nucleolar. Nucleolar pattern ends with R, so antibodies are against RNA. All these mnemonics I've told you in the main course, right? Antibodies are against RNA. Happens S matlab SR dot dot dot. Everywhere you're gonna see speckled. This dot 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 is known as speckled, and speckled has sub mein. Speckled hone wala hai sub mein. This is the most common. You can see it in anti-Smith antibody, matlab you see it in SLE. Anti-Rho and anti-La means you see it in Sjogren syndrome. This is totally non-specific pattern. Non-specific means it's seen in every autoimmune disorder. This is the most common one found in every autoimmune disorder. And finally, last one. Chromosomes are getting highlighted. This means the C stands for centromere, centromeric pattern. Guys, this means anti-centromeric antibody is a part of which syndrome? Anti-centromeric body is a part of the CREST syndrome. I'll be showing you a picture of CREST syndrome also, but coming all the way back, did you all analyze these 5 patterns very well? Very important question. Happens. Quick revision. Homogeneous matlab everything green against histone, dsDNA, everything. Peripheral, like only the periphery is green against dsDNA. Nucleolar ends with R, antibodies against RNA. Speckled, dot dot dot, most common. Every autoimmune disorder can show you this pattern. Centromeric, C for C. Centromeric is going to be seen only in CREST syndrome. Before I go to CREST syndrome, I hope everyone's clear with MD SOAP brain and you've analyzed all of this 11 criteria, at least fulfill 4 and SLE is done. Yes, what was it about this CREST syndrome that I had to tell you? So firstly, what is CREST syndrome? Full form batao. What is CREST? C for calcinosis, R for Raynaud phenomena, E for patient will have difficulty in eating, esophageal dysmotility, S for the picture shown over here, sclerosis, dactyly, digits. You can see the digits are becoming sclerosis, matlab very, very stiff and thick. The digits are going to become very, very stiff. So sclerodactyly, that is S. And what is T? These patients have telangiectasia. So repeating guys, whenever you write CREST syndrome, which is the antibody pattern that you're going to think of? C for CREST, C for centromeric. The ANA pattern that you shall have is going to be centromeric. So you realize that by doing these ANA patterns, not only have you covered SLE, but you've also covered CREST, and you can cover a lot of autoimmune disorders basically. Very important point. So that wraps up your this part also. We are not over. We are also left with one kind of myositis that they ask you in the paper, because that is also autoimmune. Polymyositis, dermatomyositis. Do you remember any antibodies? I hope you guys remember there is something known as anti-Jo1 antibodies. Then एक 2 वाला भी होता है, that is anti-Mi2 P152 antibodies. Then there are P140 and P155 antibodies. These all antibodies I've taught you in the main syllabus. My point over here is that when I'm talking about myositis, muscle to samajh aa raha hai, but dermatomyositis tells me derma problems are going to be there. What are the derma problems? Look at the first thing. There is a rash that is present around the eyes, heliotrope rash. There's a rash that is present on the knuckles and the phalanges that is known as the Gottron papules, that is referred to as the Gottron papules, right? Next, coming on to look at the fingers, they're very rough. What do you call it? As if it's a mechanic's hands. Then you see rash over here, guys. Can you all see a rash on the back area where you take a shawl? So that is known as shawl sign. You see a rash in the neck. That is known as the necklace sign. These are all the dermatological findings. Repeating once again. Heliotrope rash, Gottron papules. Then you have the mechanic's hands, shawl sign, necklace sign, dermatomyositis. So now you will ask me, what is the difference between dermatomyo and polymyo? One thing is to clear. What is common is myositis. दोनों में muscle involvement है. But one thing is there that dermatomyo will show you all those skin things and polymyositis will not. How do I differentiate it on a microscopy? So please remember, dermatomyositis mein you have to go and look at the periphery. The periphery is going to have a problem. So if you look carefully in dermatomyositis, you will see that all the inflammation, dermatomyositis, itis, all the inflammation is also at the periphery. And you will also notice that jo periphery pe cells hain, the muscle at the periphery is smaller, muscle in the center is bigger. So what am I noticing? I am seeing that there is a perimysial inflammation. Bahar, periphery mein inflammation hai. And perifascicular atrophy, the muscle at the periphery is becoming atrophic, means it is becoming smaller. So everything is perimysial inflammation, perifascicular atrophy, that is all periphery pe, that is dermatomyositis. Whereas what is polymyositis? Where do you see the inflammation? It is inside the muscles, in between the muscles. What do you want to call it? Endomysial inflammation. Very famous question you get to see. Endomysial inflammation. So simple P is not for P. Polymyositis mein you don't see the periphery wala things. Dermatomyositis mein you see the periphery wala things. Polymyositis mein you see inside, that is going to be endomysial inflammation. So this is done. One more itis that you have to know is inclusion body myositis. You know how I have learnt it? Inclusion body myositis is going to occur at the peak of the age, very, very old people. And the muscle group also affected is the end of the muscles, the distal group. So end of age pe hoga, end of muscles mein hoga. IBM, inclusion body myositis. So simple, end of age elderly, end of muscles distal. So what is the meaning of the word inclusion body? Yes, I can see inside the muscle there is an inclusion, inside the muscle there is an inclusion. In other words, it's looking like a vacuole. So they say these inclusions are known as rimmed vacuoles. And what are they positive for? It's very interesting to know, guys. They are actually positive for Congo red. You'll say, hang on ma'am, I know Congo red for something else. I know Congo red for what? I know Congo red for amyloid. Now, this is one thing for INICET. I want to tell you that Congo red can also be important for inclusion body myositis. Okay? So now coming on to what you know Congo red for. And the last image of general path is amyloid. All things about amyloid in one slide that I've tried to get. So firstly, whenever amyloid gets to deposit in an organ, that organ becomes very waxy. So the word waxy is always going to denote amyloid. So you can see the kidney over here has become very, very waxy. So amyloid wala hai. What is the stain? The very famous stain for amyloid is Congo red. If I look at Congo red under light microscope, to ye to hamesha ma'am, light microscope always looks pink. So you're getting a salmon pink color, nothing very fancy about it. But as soon as I look at under polarizing microscope, look at this color. It's looking like the very famous what? We all know it. It's looking like the apple green birefringence. It's looking like apple green birefringence, right? Okay, this is the most important stain, Congo red. Acha, one more stain you get on which you don't get an image. Jaldi se tell me. If I want to use thioflavin T, if I want to use thioflavin T, which light will I use? So TUV. I will always see it under ultraviolet light. Again, this is not an image-based question, but this question has come 1 million times in PYQs. Thioflavin T is for amyloid, and thioflavin T ke liye UV light you need. Finally, coming to the last thing, amyloid, black and white picture, electron microscopy. You will not see any branches. You will see non-branching fibers. You don't even have to know any length, indefinite length. So nothing, ma'am, I don't have to know any branching. I don't have to know any length. I just have to know one thing, and that is the diameter. Can you tell me the diameter diameter? It is, yes guys, 7.5 to 10 nanometers. This is the previous year question again, 7.5 to 10 nanometers. So remember, waxy apple green birefringence, diameter 7.5 to 10 nanometers. Amyloid is done from rapid review. You've done all the theory of the 3 tables of how and where amyloid gets deposited, and that wraps up all of your most important images of general path. So having discussed the images of general pathology, now let us move on to the next and the most important part of our snapshot section, and that is systemic pathology. We'll try to go in a chapter-wise manner so that you're more oriented to your theory and your images alongside. But before I start with all the biopsies and the tissues and their images, it is very important that we quickly revise how are these tissues processed. What is tissue processing? So you can see a closed tissue processor over here and an open tissue processor. Basically, this is where all the biopsies are put. As soon as you have an endometrial or a prostate or any biopsy, it is put into this machine. So what all is going to be here? What are the chemicals? We say fix the concept in your brains. Means the first thing that is going to happen is going to be fixation. There are lots of fixatives like formaldehyde, glutaraldehyde. I'll give you a list. So fix for fixation. The for D, so this means next step is you put the tissue into alcohol or acetone, something that is going to remove all the water from it, dehydration. So fix the C for clearing. You're going to clear the tissue. In order to clear the tissue, we have chemicals called xylene. How I have learnt it? To clean, you have xylene. To clean, you have xylene. So simple. Fix the concept. What is in? In for impregnation. So please note, impregnation means you're going to put impregnate. Once you've cleaned it, you put something inside it. What do you put inside it? You put wax inside it. And in your, so nothing it with your, but brains. B for bedding and blocking. What is embedding and blocking? Please note that if this is, for example, your L mold. What is L mold, guys? L mold matlab Leuchart mold. Leuchart mold is also known as L mold. Why? Because it looks like L shape. There is one L like this and then there is one L like this. So one L like this, one L like this. What have you done? You put the tissue inside it. That tiny little endometrial biopsy or whichever colonic biopsy, chalo jo bhi biopsy is there, whichever biopsy you have, you put that biopsy and you make an L around it, because inside it you are going to now fill it up all with wax. That is known as embedding. You are making a wax block. So what do? You're going to do bedding and blocking. You put wax and you make a wax block. So after you've done B and B, brains matlab bedding and blocking. So brains may you will also consider the S and the end. Why? Because now you're going to go ahead and do section cutting. I'll show you what you're going to do. See, what did you do over here? You had put your tissue inside it and you had made a block. Wax ka ek block bana liya. Now look at this. Can we all appreciate there is a wax block with that tissue inside it? Zoom in karke dekho, there is a wax block and a tissue inside it. Same way there's a wax block and a tissue inside it. What are you doing? Now you're cutting. Now you're doing section cutting. So cutting with a blade. You can see a blade over here, a blade over here. So it's like, you've seen those sewing machines, how the tailor spins the wheel at one end and the needle keeps moving. Same way, you keep spinning the wheel and the section keeps getting cut. So dekho, yahan se you're going to spin the wheel and the section will keep getting cut. Rotate the wheel, cut the section. Rotate the wheel, cut the section. Rotary microtome is what is used for cutting, for section cutting. And finally, you are going to put in the typical pink and blue of pathology. So let's do a repeat. What do you mean by fix the concept in your brain? Fix stands for fixation. The stands for dehydration. C for cleaning or clearing. Fix the concept in for impregnation. In your brains, B for bedding and blocking, and S is going to be for section cutting. After your section cutting is done, then you go into the HNE. HNE means the pink and blue of pathology. So the two questions that come over here is what are the fixatives and what is this HNE? Ye bacha. So let me tell you the two fixatives. Remember, if you're going in for light microscopy, what is the most common fixative? 10% neutral buffered formalin. If you're going in for electron microscopy, then the fixative that you have is going to be glutaraldehyde. So remember these set of fixatives. images because they're very important for the exam. Okay? Now let's move forward. This was about your fixatives. I want to now tell you about this pink and blue, that is HNE. What is it about HNE? So सबसे पहले you say, ma'am, one is blue, one is pink. So where did you get it from? So I'll write it again. The blue color dye is known as hematoxylin. The blue color dye is called hematoxylin and the pink color dye is referred to as eosin. Okay? That is what you do in pathology, the pink and blue. There's a history which goes down for this hematoxylin and they could give you that which is the dye which is obtained from the tree bark. Heartwood of logwood. Heartwood of logwood tree known as Hematoxylon campicianum. Even if you don't know the full name, but you'll know that Hematoxylon hai. Campicianum, even if you don't remember, but Hematoxylon means hematoxylin has come and this is known as heartwood of logwood tree. So I realized that hematoxylin has actually come from a tree and that is how I got this entire stain. So I hope everyone's comfortable with it, hematoxylin and eosin. But if you have to stain, what will you dip the slide in? What will you fill up? You put all the solution in a jar. Remember, it could be a plastic jar, it could be a glass jar, but the name of the jar is the same, that is Copeland jar. So if you want blue color, you put blue color into it and put your slides inside it. If you want pink color, then you put eosin into it and you put your slides inside it. Whenever you put your slide inside, that is a Copeland jar. So you'll say, finally, ma'am, my slide is ready. What do? I have to protect it. My slide should not dry. So what do? The last step that you have is mounting. So you're going to put a drop of something and cover it with a cover slip. So can you see? I've put a drop of something known as a media, known as mounting media. And on top of it, I have added a cover slip. So they ask you, what was the oldest mounting media that was used? That was Canada balsam. That was old times. But aajkal kya karte hain? That is DPX. So just even if you don't want to learn the full form, but DPX याद रख लो. DPX stands for dystyrene dibutyl phthalate xylene. So again, this is not something which is important, but DPX for mounting is important. I hope you've understood how finally my slide is ready. Now you're going to look at this under the microscope. So your basics are done. Now let's begin with systemic pathology and start off with the very first chapter, which is right in front of you, the arthritis. Yes, the classical trio that you're going to get. Firstly, as soon as you get an image, what is this showing you? This is showing you the classical nodular thickening of the superficial temporal artery, right? Not just temporal artery, superficial temporal artery. That is the reason that my patient is going to suffer from what? There's going to be unilateral headache. There's going to be a lot of throbbing headache that my patient shall suffer from. So what will I do? I will take a biopsy. When I take a biopsy, what do I see under the microscope? I see lots of these giant cells, right? We see a lot of giant cells and granulomas. That is what is noted. So yeah, this is number one because temporal artery, temporal arthritis, and because it has giant cells, this is giant cell arthritis. And because I say giant, it is seen in that giant age. It is seen above 50 years of age, right? That's the age group that is important. And when I use this special stain, I saw that there is a blackish color line and suddenly that black color line has gone missing. That black color line is missing means there is fragmentation of the internal elastic lamina. That black color line was internal elastic lamina and that black color line has basically broken off. So what is this stain? I hope you remember elastin ke liye the stain that we do use is Verhoef van Giessen. VVG stain is used whenever I want to pick up elastic fibers, VVG, right? That totally brings up my images of temporal arthritis. Treatment, steroids. Start steroids ASAP. Now there's another T. There's one T, temporal arthritis. There's another T that you have to know, that is Takayasu, which is going to occur below 50 years of age. Okay, so Takayasu, you can see the image over here. If I ask you what is the blood vessel affected, you can very well say that the arch of aorta is affected, but which out of these is said to be the most commonly affected? So remember, the subclavian artery is most commonly affected. And basically I get to know that it's the upper limb, the upper limb wala artery. So what is the problem that is happening? I can see these arteries are getting narrowed. There is constriction. So why is there a narrowing or a constriction? That is because if you look at these arteries, I could see that yes, the lumen has become very, very narrow. Now because this lumen, why has it become narrow? Because I can see the intima. The inner layer has become very thick. So the lumen has become very narrow. This means the blood flow is going to decrease. And if the blood flow is going to decrease, the upper limb pulse is going to become very, very weak. Obviously, if your blood vessels are narrow, blood to nahi jayega. So the upper limb pulse becomes very weak and that is why I call it the pulseless disease. So this is Takayasu pulseless disease. Let's move forward. Moving on to the medium vessel. So these two, the TNT, temporal and Takayasu, these were large vessel vasculitis. Now I go on to the medium vessel vasculitis, and that is, remember medium vessel vasculitis had Pan Khata Bachcha. So Pan Khata Bachcha, I'm going to show you 3 slides. Pan is polyarthritis nodosa, Khata is going to be Kawasaki disease, and Bachcha is going to be Berger's disease, right? Pan Khata Bachcha. So let me start with Pan, that is polyarthritis or PAN, polyarthritis nodosa. As I said, it is going to be the medium vessels that are affected, with the most common vessel being renal. Renal vessels are most common affected, but glomerulonephritis nahi hota. This doesn't result in any nephritic syndrome or anything. This is not going to result in glomerulonephritis. Big no. And which is the vessel only that is never affected, guys? Come on, you know it. P is never for P. Polyarthritis nodosa is never going to involve the pulmonary circulation. That's the golden rule of this disease. And the picture I've already shown you. Remember all these 3-letter things, polyarthritis nodosa, 3-letter things used to show you fibrinoid necrosis, which you can very well see as a pink color band over here. Simple. So yes, it involves renal vessels, but no glomerulonephritis. Pulmonary is never ever involved. And now keeping the most famous question for the end. It is associated with which viral marker? It is associated with HBsAg. Very important history in the paper. So PAN, polyarthritis, is done. Now let's come to Kawasaki. Again a medium vessel. Kawasaki is gonna occur in kids. That is how we learn it. Usually, it's a less than 5-year-old kid, which is very, very important. So, repeating in front of you, K for Kawasaki and K for kids. They have a criteria. That is, fever to mandatory hai. Fever is the mandatory criteria, plus there has to be cream in it. So, what is cream in it in the cream criteria? So, first C means conjunctivitis. Usually, it is bilateral non-purulent conjunctivitis. R means the patient is going to have rashes. E for swelling, edema. A for adenopathy. Adenopathy matlab lymphadenopathy. Lymph nodes, cervical lymph nodes are affected. And M finally for mucosa. And what do you see in mucosal involvement? The very, very famous strawberry tongue. The very famous strawberry tongue is going to be seen in the mucosal involvement, and strawberry tongue is seen in 2 conditions. Strawberry tongue is seen in Kawasaki, and strawberry tongue is also seen in one infection. I hope you guys can recall scarlet fever. Hai na? So this is about the full history of Kawasaki. Now let me tell you what is the most expected question. Update. Which antibodies have been found in Kawasaki? Anti-endothelial cell antibodies. I've told you this in the rapid review and in the main videos. Anti-endothelial cell antibodies are going to be present in Kawasaki. Coming to the next, Pan Khata Bachcha, so that is Berger's, and I hope you know this is a NEET PG question and FMG question, dono recent ones. Other name for Berger's, TAO, so break the word, there's going to be thrombus, blood clot. Itis, inflammation, so there's blood clot, inflammation, matlab the full vessel is obstructed. Obliterans. Thromboangiitis obliterans. Why does it happen? So again, B for Berger's, B for BD. So this is associated with smoking, BD or any kind of smoking. And how is the patient presenting? Dekho, vessel ka lumen is totally gone. So the patient is going to present with intermittent claudication. They will say that there is pain in the legs while walking. There is pain in the legs at rest. So some kind of pain, claudication in the legs, that is a typical history, and the person will always be a chronic smoker. So remember, Berger's for BD. Okay, Pan Khata Bachcha done. So medium vessel done. Now let's come to small vessel. I hope you all remember small vessel vasculitis was associated with ANCA antibody. What is ANCA antibody? Anti-neutrophilic cytoplasmic antibodies. ANCA were of 2 types. You have to remember this. C ANCA and P ANCA. Inka dusra naam. CPR. C ANCA is also known as PR3 ANCA. And P ANCA is also known as MPO ANCA. So please note, how will I identify? What are these pictures? These are immunofluorescence wala photos. And how will I identify them? See, C stands for cytoplasmic. So I will see that the entire cytoplasm has become green in color, not the nucleus, only the cytoplasm. Whereas P refers to perinuclear. I will realize that everything around the nucleus has become green over here. So remember cytoplasmic and perinuclear, C ANCA, P ANCA. So now note that if they ask you what does Wegener's granulomatosis show, so Wegener's granulomatosis shows you both C ANCA and P ANCA, but वो Wipro company याद है ना, Wegener's more commonly shows you what? So Wegener's more commonly shows you PR3 ANCA. Wegener's is more commonly going to show you PR3 ANCA. Coming to the next, where do you see the others? So देखो, P ANCA are gonna show you pan, मतलब everything else. It will be seen with microscopic polyangiitis. That is exactly what I'm gonna show you. It will be seen with microscopic polyangiitis. It will be seen with Churg-Strauss syndrome. So all the other vasculitis are gonna show you this P ANCA, pan, मतलब सब कुछ दिखेगा. But this P ANCA is also seen with two conditions other than vasculitis. One condition in the intestine, ulcerative colitis. One condition in the liver, primary sclerosing cholangitis. So genuinely this P ANCA, MPO ANCA is the papa of everyone. It's like the father, it's giving birth to everyone. Ulcerative colitis, primary sclerosing cholangitis, Wegener's, microscopic Churg-Strauss sub mein. Wegener's is seen in both, but more commonly Wegener's shows you what? PR3 ANCA. So now starting with that Wegener's only. Again, Wegener's is very, very famous for showing you, the name only tells you, it shows you granulomas. Where all do you see granulomas? Of course, we see granuloma in the blood vessel, we see granulomas in the kidney, and we see granulomas in the lungs. So remember, in the blood vessel, the kidney and the lungs, granulomas are seen. So ये तो एक triad है. There is another triad which I call as ENT triad. ENT triad means these patients have ear mein there is otitis media. Then in the nose they have nasal septal perforation, which is a very, very important history that will be given to you. And throat, so otitis media, nasal septal perforation, and throat, I will say the mouth, and that is going to be the strawberry gums. That is going to be the strawberry gums. So repeating, granuloma ka triad and then ENT ka triad. That is Wegener's granulomatosis, right? I hope everyone's okay along with its association with ANCA. Vasculitis chapter is done. I can move on to the next part of blood vessel, that is sclerosis. See, sclerosis ka simple English meaning is stiff. Why is your blood vessel going to become stiff? So here we have hyaline arteriolosclerosis. Hyaline means there's going to be a lot of pink material that is getting deposited. Hyaline refers to pink glassy material that is getting deposited, and you see this in cases of benign hypertension and diabetes. Benign hypertension as well as diabetes mellitus. How do you see hyperplastic arteriolosclerosis? Hyperplastic matlab there is going to be something hyperplasia, something is increasing. So as a round and round, what appearance is this looking like? Hyperplastic arteriolosclerosis is looking like onion skinning. So which hypertension do you think is going to show you? Of course, the only one that is left, that is malignant hypertension. So that is also seeming quite easy. So if they ask you benign hypertension, it is hyaline arteriolosclerosis, and malignant hypertension, hyperplastic. What is one sclerosis? Monckeberg sclerosis बचा है. But go back to your first chapter. I've taught you Monckeberg sclerosis का दूसरा नाम, it is also known as CMD. It is known as calcific. Yes, I can see the calcification. I can very well see the calcification where calcific medial मतलब tunica media. Where was it? Look at it carefully. All that blue color calcium is coming in the tunica media. And what exactly is it, guys? Degeneration, old age hai bas. It's no disease, it's no bacteria, virus, parasite. It's just some old age phenomena. So calcific medial degeneration is nothing but Monckeberg sclerosis. These three scleroses are sorted, but the most well-known sclerosis to all is definitely atherosclerosis, hai na? So this you can see. What are the key questions that you're gonna get? Atherosclerosis is like very old, is a very prolonged or a very long-term complication. How does the disease start? It starts off with a tiny little streak. So if someone asks you what is the first lesion of atherosclerosis, it is a fatty streak, a tiny little yellow color line. That's about it. After some time, there is a proper plaque that is going to form. So that is referred to as a plaque, and they ask you that what is the location of the plaque, and that is below the intima. It is going to be subintimal. So yes, it is seen below the intima, that is subintimal. What beyond it can occur? Beyond it, there can be complications. I'm not dealing with obviously the the entire theory part of it, but I think we can quickly have an overview of what were the complications that can occur. Can you tell me? I give you a mnemonic of acute. A for aneurysms can occur in the blood vessel, calcification can occur, ulceration is possible, and T and E means thrombosis and embolism. Thrombosis and embolism can occur. So repeating, aneurysm, calcification, ulceration, thrombosis, embolism. These are the different complications known over here. So yes, this is about atherosclerosis, which is important. Sclerosis over, let's go on to the next topic. What are the images that you have to know for vascular tumors? The most common, OMA, benign wala vascular tumor, hemangioma, recent exam questions in NEET and FMG. Listen very carefully. If you see tiny blood vessels like this, chota, small size blood vessels, it's gonna be a capillary hemangioma. Chota, small size blood vessels like a capillary hemangioma. Whereas if you see such huge, big channels, such huge dilated channels, that is going to be indicative of a large cavernous hemangioma. So repeating, small blood vessels capillary and dilated blood vessels are going to be cavernous hemangioma. How is their site decided? Remember, superficial is going to be the site for capillary hemangioma. They will always say skin. These are capillary sites, skin or the face, capillary sites. Whereas if they mention deep tissue or they mention some kind of an organ like the liver or the colon, any organ or deep tissue mentioned, cavernous hemangioma. I hope you also remember cavernous hemangioma was associated with that very famous syndrome called the VHL syndrome. Let's move forward. We are not over. The next blood vessel tumor that you have, pyogenic granuloma, the most incorrect statement I have ever heard, because neither is it associated with bacteria nor is it a granuloma. Wrong question at all. Na pyogenic hai na granuloma hai. The real name is, it's a pregnancy tumor. Yes, it occurs in pregnancy. Pregnancy female comes to you with a mass in the gums or the fingers, reddish, but pregnant history hoga. So the only question they will ask you is, how does it look like under the microscope? And under the microscope it is LCH. What is LCH? It's a lobular capillary hemangioma. Tell me something. Capillary hemangioma hi hai means big, chota blood vessels, na? So if it's capillary hemangioma, yes, the blood vessels are very tiny. But I've added the word lobular, means that there is a lobule here, there is a lobule here, there is a lobule here, maybe a chota sa lobule here. That is why I call it LCH, lobular capillary hemangioma. Okay? So this is having a very classical history of pregnancy. Moving on to the next, the very famous glomus tumor. Glomus tumor ka origin is going to be from the glomus body. And let me tell you, all of us have a glomus body. Where do we have a glomus body? On our fingertips. Glomus body is normally an AV anastomosis that God has given you. It's an AV anastomosis that God has given you on your fingertips. Why? For thermoregulation, for maintaining your day-to-day temperature. God has given you glomus body. From that, tumor ho gaya. So if glomus body is on the fingertip, the tumor will also be on the fingertip. The site of the tumor is going to be subungual, that is nail bed, and I can see that it's a hardly pea size 1 centimeter tumor, but the amount of pain that it causes is excruciating. So these two histories are given: excruciatingly painful lesion on the nail bed, and that is a glomus tumor. Coming to the next, whether it is a tumor or not, big time controversy, but there's something called bacillary, matlab some bacteria. Angiomatosis means blood vessel problem. So yes, hai to blood vessel problem because of some bacteria. What is the bacteria, guys? It's the very famous Bartonella henselae. I hope you remember. Why have I made a cat over here? Because Bartonella henselae, number 1, causes bacillary angiomatosis. Number 2, it also causes the very famous cat scratch disease. So there are 2 things which are caused by Bartonella henselae. And what is this picture shown? Why is it an image-based question? Because it looks like this black organism. Bartonella henselae is looking black. Why? What stain has been used? Warthin starry silver stain. Remember, Warthin starry silver stain, WSSS, is used for 2 things finally in the entire path and micro that we can memorize. One is going to be Bartonella henselae, and the other is, of course, the very famous H. pylori. Okay, so this is also done. Let's move on to the next tumor, which is examiner's favorite, and that is Kaposi sarcoma. Now, firstly, what is the organism that causes Kaposi sarcoma? It is human herpes virus 8, and it is usually seen in some kind of an immunodeficient person like HIV, right? What is the site? Most commonly, again, it's going to be the skin, and it's going to occur along the lower limbs. The lower limbs or the thigh is the very common site that you have, and you will see these reddish lesions. Because it's a blood vessel tumor, you'll see red lesions. So when you look at it under the microscope, you will realize that yeah, blood vessel tumor hai, there's a lot of hemorrhage. So there's a lot of hemorrhage, and the channel, see, blood vessel aisa gol hota hai na, suddenly the blood vessel becomes aisa slit like. There are slit like blood vessels that I'm going to see. And if you're preparing for INI-CET, let me tell you, on immunohistochemistry, this is LANA positive. A famous expected question going forward, that LANA positivity will be seen in Kaposi sarcoma. Very important, human herpes virus 8. Super important. Now moving forward, coming to the last tumor, and that is going to be hemangiopericytoma. Hemangiopericytoma sounds oma. Many people think, are ye benign hai? No guys, this is a malignant tumor. And what is so famous about it? Look at the shape of the blood vessels. This is probably looking like the horns of a deer. This is looking like the horns of a deer. So we call it staghorn or fish hook blood vessels. Very, very famous question for hemangiopericytoma. So yes, on that note, we have wrapped up all our blood vessel images, right? In continuity, why don't we cover up the cardiac images also? Let's now begin with the images of the heart. As you can see in front of you, we have heart failure cells, and I hope you remember that heart failure cells, although I say that it is heart failure, it is seen because of heart failure where it is actually seen in the lungs. So which is the heart failure which is going to affect the lungs? Of course, it is going to be the left-sided heart failure which is going to affect the lungs. And in the lungs, what do we see? We see lots and lots of congestion. So blood means hemosiderin, and hemosiderin will be eaten up by the macrophages. So what exactly are heart failure cells? Heart failure cells are hemosiderin-laden macrophages. And guys, if I have to stain hemosiderin, we all know that for iron, there is a very famous stain known as Pearls or Prussian blue. So here exactly this is what we are going to see, reminding you, heart failure cells, left-sided heart failure involves the lungs. So they are seen in the lungs because of left-sided heart failure. Then what do you see in right-sided heart failure? So please note, in right-sided, because when the right side of the heart will fail, there is chronic venous congestion that can happen in liver, in spleen, and so on. So when chronic venous congestion happens in the liver, it results in the formation of a nutmeg liver. It looks like this nutmeg over here, dark and light, dark and light. So dark areas, light areas, dark areas, light areas. So I just want to tell you that this is a question that came in your previous year NEET exam, that the dark areas that you have over here, they are going to be the ones which are showing hemorrhagic necrosis. They ask you which is the necrotic part. The hemorrhagic necrosis is the dark area, whereas what is the lighter area that you have? That is nothing but fatty change. The light area is going to be fatty change. So repeating, as you're seeing over here, this dark area that you have, that is hemorrhagic necrosis, and the light area that you're seeing, that is fatty change. Again, dark area necrosis, light area fatty change. That is the nutmeg liver, which is a chronic venous congestion seen in right-sided heart failure. Coming to a case of myocardial infarction, guys, if I ask you what is the first light microscopic change that you will see? The first light microscopic change that you see between 30 minutes to 4 hours is going to be the waviness of the fibers. As you can very well look at over here how the fibers are becoming zigzag. So waviness is something noted as the first light microscopic change. But if you guys remember, if I ask you what is the first gross change, you will say, ma'am, the first gross change is seen even after 4 hours. So there was one stain of the heart that was really helping me for the gross diagnosis within 4 hours of MI. When nothing is visible, I can put this stain and identify. And what is that stain known as? The TPTC. So I always used to tell you that TPTC has 4 alphabets, and this is useful in the first 4 hours of MI. Triphenyl tetrazolium chloride. The principle is that this tends to stain the LDH1. So we all know that a normal heart which has normal LDH1 is going to get a normal brick red color, right? So the normal brick red color means that LDH is fine, and that is why I've got that color. Whereas when I see this area in which MI has occurred, this means that the LDH has gone, and if the LDH has gone, that area has basically become pale, and that is how you identify the myocardial infarction. So this is the area undergone an infarct. Remember, TPTC, 4 letters, useful within 4 hours. Another thing that can happen in MI is something known as reperfusion injury. After you give therapy, after you do stenting, after you give thrombolytic therapy, something like reperfusion injury can occur. And the reason for reperfusion injury, as you will study in your course, is either free radicals or it is because of calcium, but more because of free radicals. And what are these that are formed? There are these bands that are formed over there, and those are referred to as contraction band necrosis. Very, very important. Contraction band necrosis seen in reperfusion injury due to free radicals. After MI, the next set of pictures that we have is the very, very famous endocarditis, and you can see the 4 endocarditis written in front of you. So if I ask you that what are these yellow things, all of them are going to show you vegetations, hai na? So how are their vegetations going to be? Vegetations are also known as verruca, clinically known as verruca. So in rheumatic heart disease, I can see there are very, very chota small warty vegetations that are there. In infective endocarditis, they are huge. They are very large and bulky vegetations. Let me show you pictures. Look at this. In rheumatic heart disease, you can see very chota, tiny vegetations, hardly visible, tiny vegetations are noted. Whereas in infective endocarditis, you can see big, bulky vegetations which are present. They are destroying all the cusps also. That is the difference. What do you see in NBTE? NBTE is also chota, but they are very fragile. These vegetations are extremely fragile, very, very friable. So this means, are they going to show you embolization? Are they going to spread to different parts of the body? Yes, definitely yes, an answer to that. But also note, in infective endocarditis, the size was so huge, they can also break off. Sometimes they can also show you embolization, but that is plus minus. Others are not going to show you at all. Just remember which are the two which can show you embolization. Infective endocarditis, kabhi because of the big size sometimes. And NBTE, non-bacterial thrombotic endocarditis, because it is weak, it is always going to show you embolization. Coming to the last one, LSC, I hope you remember Liebman-Sachs endocarditis is seen in, rearrange the terms, SLE mein dikhta hai, and what do you see? You see vegetations which are present on both surfaces. How did we learn it? LSE means you see vegetations everywhere, but where are they more common? Dekho, upper bhi dikha, lower bhi dikha. But where are they more common? LS tells you they are more common on the lower surface. And that is how you identify LSE vegetations. Out of these, please note, all of them are gonna be sterile vegetations. Means they're not, yahan bacteria nahi milega, you won't get the bacteria here, you won't get the bacteria here, but you will get the bacteria in infective endocarditis. The only one which is infected or non-sterile, the only one which is infective or non-sterile is infective endocarditis. Rest all of them are sterile. So repeated, in non-sterile matlab infected na. So how I have learned it is infective endocarditis is infected vegetation, as easy as that. Let's move forward. Because I was talking about rheumatic heart disease and I saw very, very small warty vegetations, I'll also see what will you see under the microscope. So what is the most characteristic finding of rheumatic heart disease? It is the Aschoff bodies, and Aschoff bodies are made up of what? What was the necrosis in it? I hope you remember. The central part used to show us the very famous fibrinoid necrosis, and surrounding it we have cells known as Anishinkow cells. So how do these cells look like? If I look at the cell like this, it will look like a caterpillar. If I look at the cell like this, it's looking like a dot. So auli. What did I say? If I look at the cell like this, it's going to look like a very, very famous caterpillar over here, right? And if I look at the cell from the front view, it's going to look like an auli appearance. So I can see the caterpillar appearance over here, and I can see the auli. But cell same hai. The same cell, Anishinkow cell, it's about looking at it like this and looking at it like this. Okay? This is caterpillar, this is auli. So together, the fibrinoid necrosis and the Anishinkow cell is known as the Aschoff body, and Aschoff body is the most characteristic part of RHD. But what do you see in long-standing RHD? In long-standing RHD, in other words, I mean chronic RHD. Chronic rheumatic heart disease mein mitral stenosis is noted. Mitral valve stenos, narrow. Kaisa dikhega? It's looking like a fish mouth. It's looking like a fish mouth or a buttonhole valve. When the mitral valve is stenosed, means it's a long-term situation. Rheumatic heart disease seems to be done, and I hope everyone's understood all the different endocarditis photos also. Now I'm going to go on to the cardiomyopathy photos, and the first one I'll start with will definitely be the dilated cardiomyopathy. What is the most common cause? I don't know. Most common cause is always idiopathic, but if at all you have to know the most common cause, that is going to be alcohol. But if they ask you the most common genetic cause, that is going to be titin mutation. And what do you see microscopically? Microscopically, we see the famous ninja star nucleus. You can see the star over here, star over here. So please remember that once we drink alcohol, after drinking alcohol, you always feel that you are ninja. You are a ninja, and also you are the best. So you are basically a ninja star, and that is associated with dilated alcohol wala cardiomyopathy and titin mutation wala. Okay? Now let's move on to the next one. So one thing I realized that in dilated cardiomyopathy, all the 4 chambers of the heart were dilated. All 4 chambers were dilated. But when only and only the left ventricle is dilated, not everything, only and only left ventricle dilated, that is Takotsubo. Why Takotsubo? Because this left ventricle looks like a Takotsubo pot. Takotsubo is a pot basically for catching octopus in Japan. So it looks like that Japanese pot for carrying, for catching the octopus. That is why Takotsubo. But this is also known as what? This is known as broken heart syndrome. Why broken heart? Because broken heart means a lot of emotional stress. And whenever there is a lot of emotional stress, that basically means that there is a release of a lot of catecholamines. And because of these catecholamines, we get to see this left ventricle dilation. That is Takotsubo cardiomyopathy, basically emotion related, broken heart. Coming to the next one, ARVCM means arrhythmogenic, fine, patient will have arrhythmias, right ventricular cardiomyopathy. So what is happening in the right ventricle? If I see in these cases, look at this right ventricle, it started looking very, very yellow. Why has it started looking yellow? Because it has fat. Similarly, this area is all fat. Fat in the right ventricle has come up. That is arrhythmogenic right ventricular cardiomyopathy. And what causes it? Please note, I'll tell you a syndrome. If this arrhythmogenic right ventricular cardiomyopathy is clubbed with a child having these woolly hair, and a child having thick palms and soles, palmoplantar keratoderma. So what are the 3 things? Arrhythmogenic right ventricular cardiomyopathy with woolly hair and palmoplantar keratoderma. Guys, this is known as the Naxos syndrome. And Naxos syndrome ka question hai that this is a plakoglobin defect. I hope you guys have studied this again in your RR and your main course videos. Done Naxos syndrome? Coming to the next. What is the question that I'm going to ask you? What is the cause of sudden death in a very young athlete? And that is going to be your hypertrophic obstructive cardiomyopathy. So first, let me tell you that these patients show you HCM. What did I write? Hypertrophic obstructive cardiomyopathy. So the cause is MHC. There is an MHC mutation that you see in these patients. How does the heart become? The heart looks like the very famous banana shaped heart. You can draw it like this and find out. See, why is it banana shaped? So kya hypertrophy hota hai? Revise from your notes. Hypertrophy occurs of the interventricular septum. The full heart has not hypertrophied. Interventricular septum ka hypertrophy hai. You see a banana shaped heart, and what do you see microscopically? You see all the fibers are arranged idhar udhar. It is all helter-skelter appearance of cardiac muscle fibers. So these 2 pictures, banana shaped heart with helter-skelter appearance, and they will say there is a sudden death that has occurred in a young athlete. You know it's a case of HCM. Coming to the cardiac tumors, which finishes off this chapter for us. Please note, the only 2 cardiac tumors which are very important, which is the most common in adults, it is going to be myxoma, and the most common in children is going to be rhabdomyoma. The one that is occurring in left atrium, myxoma, left ventricle, rhabdomyoma. So we always used to make a chota sa heart and write Mr. in it. So M comes upar, adult, R comes niche, it's a chota bacha. M comes upar, left atrium, R is niche, left ventricle. Easy to learn. So now when I look at the word myxoma, myxoma will definitely tell me myxoid. So you get to see some jelly-like mass. You get to see a gelatinous mass along with what cells? Photo will not come, but definitely the term will come. You see lipidic cells. Whereas rhabdomyoma is very famous for showing you this spider web cell, Ratlo. As it is Ratta lagao, this is spider cell. And remember, spider cell has pass positivity because spider cell contains glycogen. Okay? Very important. So myxoma and rhabdomyoma, Mr. Mnemonic, left atria, left ventricle. This shows you lipidic cell, this shows you spider cells. This sorts your cardiac chapter. I think we are ready to take on the next chapter, that is lungs. Let's begin with the next chapter, and that is the lung pathology. Of course, the first thing that we have to know is what is the epithelium, because now you're getting a lot of questions on histology also, right? So we all know it is the pseudostratified ciliated columnar epithelium. We can definitely see the cilia over here. So that is sorted. But why is it pseudostratified? Because the nuclei are at a different level. So one of the cells has a nucleus above, one cell has a nucleus below, one has at the bottom, the other one is again above. So every nucleus is at a different level. That's why you call it pseudostratified and then ciliated columnar epithelium. So everywhere in the lungs you will find this, but of course not in the alveoli. In the alveoli you have pneumocytes. You have two types of pneumocytes, type 1 and type 2, which you find more commonly all throughout. 95% of the cases or 95% of population is type 1 pneumocytes, and only 5%, a very minor population, is going to be type 2 pneumocytes. But let me remind you that the surfactant production is actually done by type 2, right? So everywhere in the lungs you have pseudostratified ciliated columnar, but in the alveoli you have pneumocytes. And I hope you remember in the vocal cord, what is the epithelium in the vocal cord? That's also different. That is the squamous epithelium. So that's the overview of the epithelia that you have to know. Now let's go on to the diseases. So the first disease is a condition known as emphysema. I hope you know emphysema means all the walls are broken. Walls are broken, as you can see over here. You can see that all the walls are floating around. So what you see are floating septa. Guys, do you remember what were the different types of emphysema? Walls are broken, floating septa is fine, but different types are going to be, let's quickly revise, centriacinar, panacinar, distal and irregular. Irregular pe to question nahi aayega, so I don't have any image on it. Centriacinar means that only the central part is damaged, only bronchioles are damaged, alveoli are badhiya. So you will see that only the bronchioles are going to be damaged. As I zoom in, only the bronchioles are damaged, but you can see that there are so many parts over here which are totally fine. They are fit and fine because alveoli are normal. But when I go to panacinar, pan means all, everything is gone. Bronchiole, alveoli, sab kuch gaya. So sab kuch aisa hole jaisa dikh raha hai. Everything is looking like holes. Why? Because all of them have gotten damaged. Everything, bronchiole, alveoli, everything has got damaged. What is distal? Distal means only the distal part is damaged. What is the distal part? As you can see near the septa, only the alveoli, only the distal alveoli have been damaged. Rest everything is okay. So tell me one thing, which of these is associated with smoking? SS wala sound. Centriacinar was associated with smoking. Which one was associated with alpha-1 antitrypsin deficiency? So all affected. Panacinar is associated with this. And which of them will result in spontaneous pneumothorax, which is going to rupture? So the distal part will rupture, air will rupture and come out. So spontaneous pneumothorax is going to be distal acinar. All of them will show you broken walls, that is floating septa. Emphysema is done. The next disease that we have in front of us is asthma. What are the pictures of asthma that you have to know? Imagine you've got a sputum microscopic examination, and we all know that we'll be seeing the three famous C's. The first C in the sputum that you see is the Charcot-Leyden crystal, which can be seen as this needle over here. If they ask you what is the composition, you all know it is made up of galactin-10, and galactin-10 is obtained from the eosinophils. The next C that you see are the famous Seriola bodies. And what are these bodies? They are nothing but airway cells. They are airway epithelial cells, right? They are airway epithelial cells which have cuffed out and come out of the system. Finally, you see this spiral over here. This spiral is known as the Kirschmann spiral, and Kirschmann spiral is made up of nothing but mucus. So these are the three C's, as I told you. You have Charcot-Leyden crystal, then you have the Seriola bodies, and then you have the Kirschmann spiral. Three C's of asthma. Asthma, sputum microscopy. The next disease that we go on to is bronchiectasis. Ectasis means dilation. Yes, I can definitely see the bronchi getting dilated, and usually, let me remind you, the left lower lobe is the usual affected location. So I can see the bronchi getting dilated. And also what I wanted to show all of you over here, which is evident, is you can see the very, very famous tram track appearance, right? I wanted to show you the radiology or the tram track appearance also, on which you get a question. I hope you all remember there is dilation. So is there any syndrome which is very, very famous for bronchiectasis? There is Carter-Jenner syndrome, which I have taught you in your RR and main videos also. Carter-Jenner syndrome is going to be seen or is going to show you bronchiectasis. Yes? Okay, moving on. If I show you these two pictures, what are these two? Yes, the very famous sarcoidosis. Now, what are the points about sarcoidosis in a granuloma that you already know? It shows you a non-caseating granuloma. In this non-caseating granuloma, you're also going to see one more thing called naked granuloma. So these two features, though, I know from my granuloma chapter only, that usually non-caseating granuloma is seen, and naked granuloma means that the lymphocytic collar is going to be absent. That is a naked granuloma. Remember, we've done this in the previous images. Now I want you to know what are the two bodies. We see asteroid body and Schaumann body. Kahan dikhta hai? Guys, look at this. You have a giant cell over here and a giant cell over here, kyunki granuloma disorder hai. And inside the giant cell over here, you will see a star. So that's asteroid body. And here you will see something like calcium, samoma body jaisa kuch hai. That is a Schaumann body. So see, this is a big giant cell, and inside that big giant cell you're seeing 1 and 2 stars. So that is an asteroid body. Over here again a giant cell, and you're seeing calcium. So they ask you what is the composition of a Schaumann body, and I have always taught you the way you write Schaumann, that was your mnemonic also, na? Schaumann is S for sarcoidosis and C for calcium, right? But I want to ask you, sarcoidosis is what kind of a disorder? It's a multi-system disorder. So they can give you this kind of a multi-system picture, which means the most common organ that I'm talking about is the lungs. But the second most common is going to be the lymph node. It shows you potato nodes. It can also show you skin lesions. Yes, I've taught you this as well. It can also be associated with hepatitis. That is another finding that is associated. Usually I say hepatitis is viral and infection. Ye non-infectious cause hai hepatitis ka. If I ask you what is the skin test, guys, what is the skin test very famous for sarcoidosis? It is the Veem test. The Veem test is very famous for sarcoidosis. And what are the 3 blood tests that have to be there? It can show elevation of calcium levels. It can show elevation of angiotensin converting enzyme levels, and it can also show an elevation of CD4 to CD8 ratio increases, right? So calcium, ACE and CD4 CD8 ratio increases. These 3 blood tests are also very famous. Skin test is the Veem test. Okay, sarcoidosis shows you asteroid body and Schaumann body, but have you studied asteroid body somewhere in microbiology also? Asteroid means star. So remember SSS. Star is seen in sarcoidosis also. Star is seen in Sporothrix schenki also. I see a star over here and a star over here. How will I differentiate? Sarcoidosis, if you remember, it was inside the cell. There was a cell and I had drawn the star inside the cell, whereas over here it is roaming around outside. It is extracellular in Sporothrix. How have I learnt it is that Sporothrix is known as what, guys? Rose Gardner's disease. So Rose Gardner is always going to roam around only, na? Roam around outside. Rose garden will always be outside. So Rose Gardner's disease mein outside wala star hoga and sarcoidosis has inside wala star. Okay. Done with this, let's move on to the next. The very famous occupational disease, that is asbestosis. And asbestosis ke liye, if they have to give you a history, they will always try to give you some kind of a shipyard industry, and the patient will then show you asbestos bodies. How do we identify asbestos bodies? Be it this or be it this, it's a dumbbell shaped body that we have. And why is it suddenly looking blue? Because for example, if this was the asbestos fiber, what got deposited around it? Iron got deposited around it, right? And the stain for iron is the pearls or the Prussian blue. That is why it's looking blue over here. So remember, guys, this is asbestos and it is surrounded by iron. That is the reason. What else do you call it? Do we also call it the ferruginous body, isn't it? Let's move forward and exercise. Ab dumbbell ka baat aaya, I can see dumbbell, so it's time to do some exercise. If I ask you all the dumbbells, let's exercise our brain. Brain exercise karte hai. So dumbbell in the lungs we've just done, it is asbestos body. Which urine crystal is dumbbell shaped, which you will be studying shortly in this particular section of snapshot? Calcium oxalate monohydrate, not calcium oxalate dihydrate. Remember, mona is dumb. That is how we did. Mona is dumbbell. So mona is dumb, monohydrate is dumbbell shaped. What in radiology, guys, if you remember? Schwannoma. When you see radiologically, if you see schwannoma tends to show you a dumbbell shaped configuration, where schwannoma in the spine, not everywhere. Schwannoma in spine shows you dumbbell shaped. And which virus in microbiology is gonna have a dumbbell DNA? You can see a dumbbell DNA, yes. So please remember, the DNA dumbbell is pox virus. I hope everyone's okay with this. These are all the dumbbells that you have in path, micro and radiology. Coming back, let's go on to a picture which is only important if you're targeting INI CET exam, and that is PAP, pulmonary alveolar proteinosis. There's a lot of protein. You can see aisa alveoli. See, sabse pehle split the word. When I say alveoli, you will say, okay, I am seeing a lot of these large spaces. They are alveoli. Then I'm seeing proteinosis. Proteinosis means I'm seeing a lot of proteinaceous material, and yes, I'm I'm seeing a lot of pink material inside it. Why? Because there's mainly a surfactant problem. The main concern over here is a surfactant issue or a surfactant defect. So in the children, it is an ABCA3 defect. It is an ABCA3 defect, and in adults it is a GM-CSF defect that you have. So simple way of learning is बच्चे learn ABC, तो बच्चों में ABCA3 defect, and बड़ों में in big people it is GM-CSF defect. What you see on electron microscopy for the INI-CET exam is important. It shows you these lamellations, because now tell me who makes surfactants? Type 2 pneumocytes, I just told you. तो कहाँ का photo होगा? Type 2 pneumocytes का photo होगा, because it is primarily a surfactant problem. Let's move forward and talk about the next picture, which is the very, very famous picture of plexiform lesions. What are plexiform lesions, guys? You can see there is a pulmonary artery. I'm telling you it is pulmonary artery, but you can see it's formed a duplication. ऐसा double artery लग रहा है. This is something you see P for P. Pulmonary hypertension shows you plexiform lesions. Repeating, pulmonary hypertension shows you plexiform lesions. Guys, can you tell me what is the genetic defect of pulmonary hypertension that they can ask you in the exam? BMPR2 gene defect. This is again a medicine question that can come up. BMPR2 gene defect associated with pulmonary hypertension and this doubling of the blood vessel, that is a plexiform lesion. Coming to the disease that became very famous in COVID, and that is ARDS. What is ARDS? Adult Respiratory Distress Syndrome, ARDS. And how do I identify it? So number one, it can be seen associated with COVID. Secondly, it can be associated with transfusions, guys. I hope you all remember in blood bank there is something known as transfusion related acute lung injury, TRALI. TRALI is nothing but this only, because the other name of ARDS is going to be ALI. ALI means acute lung injury. ALI refers to acute lung injury. So please note, adult respiratory distress syndrome or ALI, that is acute lung injury, can be associated with transfusions, can be associated with COVID. And kya hoga? There is a hyaline membrane in the alveoli. We have the formation of a hyaline membrane that is formed. That is why the patient has difficulty in breathing. Let's move forward. We're going to go on and talk about all the different tumors of the lungs that we have. So let us start with the benign tumor. The most common benign tumor of the lung that we have is pulmonary hamartoma. I want all of you to remember that story. Hamara tissue, hamare paise, hamara popcorn. Remember, hamara tissue means it's more of what tissue? It's the more and more of cartilage. So there's a lot of cartilage. Basically, cartilage is own tissue. Na? Lungs anyway have cartilage. Now you have more of cartilage. So hamara tissue, lot of cartilage. What is it? Hamare paise means what do you see radiologically? You see a coin lesion. And if I have the money, then I eat the popcorn. So what is the calcification? The calcification is popcorn calcification. So please note, hamara tissue, hamara toma. Hamartoma is hamara tissue, hamare paise, hamara popcorn. I want all of you to tell me popcorn calcification other than hamartoma is also seen in a breast tumor, that is fibroadenoma, right? That also shows you popcorn calcification, isn't it? Okay, this was one benign tumor. Now let's go on to a tumor that may be benign, may be malignant. And that tumor is known as the carcinoid tumor. So can you tell me the cell of origin? From which cell is it arising? One very, very weird sounding cell called the Kulchitsky cell. It is arising from the Kulchitsky cells, and you can see this lesion over here, it's looking like a coat button. That is how they define it. Carcinoid tends to show you the coat button lesion. Okay, then when you look at it, at the end of the day, I know carcinoid is a neuroendocrine tumor, and if I know neuroendocrine tumors, I know they have some things in common. Firstly, their pattern, they will always show me nests and nests. I can very well see, if I zoom in, I can see these nests that are formed. So there's going to be a nesting pattern that is noted. Apart from that, because it's neuroendocrine, on electron microscopy, you see these black dots, neurosecretory granules. That tells me that, okay, neurosecretory hai, so it is a neuroendocrine tumor. Be it, can it be benign? Yes. Can it be malignant? Yes. Remember, carcinoid can have varied potential. These were all benign tumors. Now I'm going to move on to malignant tumors, and you know this picture very, very well. If I show you the presence of these, what are these? These are the very, very famous keratin pearls. Keratin is produced by squamous, so this is a squamous cell carcinoma. Also, I can see these cells are held by these can you see the cells are held by tiny, tiny spines? Yes, because squamous cells are very famous for having desmosomes. So remember, this is just a miscellaneous finding, but the main finding is this pink wala pearl. Pink wala pearl is keratin pearl. As soon as I say keratin pearl, anywhere in pathology, squamous cell carcinoma. But when we are talking about lung tumors, they ask you the markers, and the markers are P40 and P63, out of which P40 is the best marker. And I hope you all remember the mnemonic, that is P for pearls and P for the PP wale markers are gonna be there, because now the next one that I show you, whenever you see the presence of glands, you know for a fact that you're dealing with adenocarcinoma. So A for adenocarcinoma, A for all the AA and A's first alphabet, na, so 1 wala things. There is napsin A, there is MUC1, there is TTF1. So all these 1 and AA stuff is gonna come up in adenocarcinoma. Adeno word means it's gonna show you glands. And what is this brown color stain? This I've told you so many times. Brown color stain is immunohistochemistry, means these markers must have been put. But this is adenocarcinoma. Is there any precursor lesion that happens? Yes, there is something known as adenocarcinoma se pehle. So adenocarcinoma in situ means that is the precancerous lesion. That is what you call it now, making sense that adenocarcinoma is cancer and adenocarcinoma in situ is pre-cancer. But earlier they used to call it back. Earlier they used to call it bronchoalveolar carcinoma. And what is the pattern that it shows you? Guys, this is a very famous butterfly on fence or lepidic pattern. Butterfly on fence means that if this is a fence, then you will always see that the butterflies are sitting on top of it. Same way, if this is the alveoli, I am seeing tumor cells are sitting on top of it. Tumor cells are sitting like this. Are they going here and there? No, there is no invasion. Invasion is absent. There is no invasion. That is the reason it is still pre-cancer. Invasion ho jayega, then to it's going to become proper cancer. There is no invasion. The butterflies are sitting very innocently like this. They have not gone here and there as of now. Okay, so squamous done, adeno done. The last one that we have is small cell. Remember my mnemonic always in the videos, I say that small cell is sounding small but is chota packet bada dhamaka. It's going to show you a lot of things. So the first picture that it shows you is the Azzopardi effect. What is Azzopardi effect? It's a blood vessel. Blood vessel is supposed to be red blood, but no, this is a blue blood vessel. That is exactly what is Azzopardi effect. What is blue blood vessel? It is the cancer cell. The DNA has come over here. To prove karo. What is the stain for DNA? The stain for DNA is the Fulgen stain. The stain for DNA is Fulgen stain. How did we learn it? DNA runs in your generations. DNA runs in your generation. So DNA ke liye Fulgen stain. Okay, Azzopardi effect, blue blood vessel, we can very, very well see here. Next, look at these cells. If I zoom in, they are white and dark, white and dark, white and dark. They're dot, 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 white and dark, matlab salt and pepper. This tends to show you salt and pepper chromatin. And at the end of the day, the same picture has come up. Because small cell carcinoma is a neuroendocrine tumor, it shows you the same neurosecretory granules. So these granules were coming up where? They were coming in carcinoid, because carcinoid was also a neuroendocrine tumor. The same granules are coming up in small cell also. Cancers are done, but these are all cancers in the lungs. Now I'm going to ask you, what is the cancer that occurs around the lungs? Means what is the cancer that occurs in the pleura? And that cancer is mesothelioma, right? So now I always say you have to differentiate mesothelioma for adenocarcinoma. Why? Because they have something common. Both of them are associated with one kind of a occupational hazard, that is asbestosis. So what will I do? I will look at their electron microscope. If I see very carefully, adenocarcinoma, no means no. So what kind of villi do they have? No branching. Chota villi. Chota villi are going to be there. There is no branching that you would see. Whereas when you're talking about mesothelioma, thelioma matlab long. There are going to be extremely long branching microvilli that you're noticing. So simple hai. Adenocarcinoma, non-branching, no means no, and mesothelioma, long branching microvilli. A question which is not an image-based question but will be asked, what is the new marker that you have for mesothelioma? Remember, it is calretinine positive. Again, a question that is coming up nowadays a lot. And with that, we wrap up our discussion of the entire lung pathology. Now, what do we move on to next? As I will show you, you will know that we are going to move on to the very famous GI and hepatobiliary system. So, the first one is in front of you. It's a barium study. Barium study showing you what? The very famous bird beak appearance. And bird beak appearance is seen in a disease known as achalasia cardia. It is seen in achalasia cardia. Achalasia cardia, if I relate it with microbiology, it is associated with a very famous infection, that is Trypanosoma cruzi or Chagas disease, right? And how does the patient present? There's difficulty in eating. Patient will say, I have dysphagia. But what is weird is the dysphagia is more to liquids than to solids. That is very important to note. And this bird beak appearance is so very, very famous. This is about the first esophageal etiology that I want to talk about. The second one is referred to as when the esophagus starts looking like a cat. Esophagus is looking like stripes of a cat. That is feline esophagus. Feline esophagus kab dikhta hai? So the way you say feline anyway sounds like something to do with E, and that is when there are lots of eosinophils. It is an eosinophilic esophagitis. Do you guys remember from hemat, eosinophils are the orange color wala cells, and I can definitely see that there is a bunch of lots and lots of orange color cells. There is a bunch of lots and lots of orange color cells, right? How many? More than 15 eosinophils have to be there per high power field. That's the cutoff. So remember, eosinophils in the esophagus, at least 15 eosinophils per high power field makes the esophagus look like these rings. That is a cat ka stripes, feline esophagus. Let's move forward and talk about the most famous disease of esophagus, that is Barrett's esophagus. Now you all know that normal Barrett's kya hota hai? Barrett's is a kind of a metaplastic change, right? It's a metaplasia that has occurred. So you all can visualize over here that this, let me zoom in and show you. This pale area here and this squamous epithelium here, ye normal hai. This is the normal esophagus. So normal esophagus has which epithelium? Normal esophagus has squamous epithelium. Normal esophagus is going to look pale pink in color. But when we see the presence of which epithelium? When we see the presence of intestinal columnar epithelium. Intestinal columnar epithelium, and we see the presence of velvety red areas, like you're seeing these velvety red areas, you know we are dealing with Barrett's esophagus. So normal epithelium was squamous and intestinal columnar epithelium is the Barrett's esophagus. So what is special about intestinal columnar epithelium, as I can see over here? I can see the presence of these very cute little cells, and these are known as the goblet cells, right? And what do goblet cells contain? Goblet cells, which are the hallmark of this disease, contain acidic mucin, A for A. Acidic mucin is stained by blue. Why are they looking so blue? Because they're stained by Alcian blue. So have a look at these goblets. These goblets over here, they are blue because I have stained them with Alcian blue. So remember, that is what is Barrett's esophagus. And Barrett's esophagus, now let me show you. I'm going to show you two cancers. You're going to tell me what is Barrett's esophagus going to lead to. But because this is definitely pre-malignant, it is definitely pre-malignant. And if I show you these two pictures, firstly, whenever you're seeing the presence of keratin pearls, you know which tumor is it? Keratin pearls is squamous cell carcinoma, hai na? And whenever you're seeing the presence of glands, that means that is adenocarcinoma. Now tell me, Barrett's esophagus leads to what? Think, Barrett's esophagus also had glands. So they will obviously lead to the glandular one. Barrett's esophagus is going to lead to adenocarcinoma. So please remember, Barrett's esophagus is going to result to adenocarcinoma. That's a very famous question that you get. And that is the reason that because Barrett's esophagus occurs in the lower part of the esophagus, adenocarcinoma occurs in the lower part of the esophagus. So please remember, the lower part is going to be adenocarcinoma, whereas the rest of it is going to be squamous cell carcinoma. Understood? These were the main tumors. So this is all the etiologies that you had to know in the esophagus, because now I'm going to go on to the stomach. Jaldi se stomach ke normal cells kar lo. See guys, the cells which are at the top, which are going to release all the mucin, the cells which are looking all khali at the top and they are releasing all the mucin, these empty cells are all the foveolar cells. Then you have two cells, parietal and chief. One is pink, one is blue. Everything in pathology is pink and blue. So you say, ma'am, let's put a logic that P for P. Parietal cells ko pink banate hain. Let's make it pink and let the chief cells be blue in color, right? So that makes life a little easier. So I can pick up these pink wala cells are parietal cells and these blue cells are going to be the chief cells. Easy to identify for everyone. Foveolar are for mucin, parietal are pink, and chief cells are blue. Now let's go on to the diseases. Before I start, I hope everyone is aware that when I'm talking about the stomach, there is definitely one bacteria that takes away all of the highlight, and that is the Helicobacter pylori. Guys, do you remember Helicobacter pylori is a urease producing organism, and urease test mein ye pink color aata hai, so it's a urease positive organism. And what is the most famous stain for it? The WSSS, Warthin Starry Silver stain. Don't forget your basics. If the word silver comes, this means everything is gonna turn black, as you can see over here. So Helicobacter pylori. And if I ask you what are the two cancers that it's gonna cause? Number one, it's going to cause adenocarcinoma in the stomach, and number two, it's gonna cause maltoma in the stomach. So basically, both of them are stomach cancers that it shall be causing. So let me start off one by one and let me talk about this cancer. But before cancer, forget Helicobacter pylori and forget all of this. Listen to this one very famous thing over here. This is hardly looking like the stomach. This is looking like the brain. When does the stomach start looking like the brain? When you're dealing with Menetrier's disease. And guys, as I write the word Menetrier's, of course, the gender is going to be more common in men. And what is the reason? This is because of TGF alpha increase. They will give you options like TNF alpha, TGF beta. Don't get confused. So remember, G and A for gastric. TGF alpha is how you will define this gastric disease. So ho kya raha hai? What is happening? I'm seeing that the stomach is looking like the brain. So grossly it is becoming giant cerebriform rugae. It is looking very similar to the brain. But if I look at it under the microscope, you'll say, ma'am, under the microscope, which cell will increase? Foveolar, parietal or chief? So remember, there is a foveolar cell hyperplasia that is noted. Lots of foveolar cells are there. And how does the patient present? Patient will stop absorbing protein. It is a protein losing enteropathy. Protein sara chala jayega. Protein lost means the patient lands up with edema. So repeating, this is more common in men. It is TGF alpha. It is a protein losing problem. So patient has edema. The stomach looks like the brain, cerebriform, and the cells increasing are foveolar cells. Let's move on to the next one. What are the cancers that you have in the stomach? The very famous diffuse gastric cancer. Before I begin, I hope everyone remembers, diffuse gastric cancer was associated with loss of E cadherin. Do you guys remember? Loss of E cadherin is two things. Number one is going to be diffuse gastric cancer above, and the other one is invasive lobular carcinoma in the breast. Remember, GOLU tumors, GO for gastric cancer and LU for lobular cancer. So GOLU tumors with loss of E cadherin. How is the stomach looking? Diffuse. The tumor is growing diffusely. The stomach has become like a leather bottle. Leather bottle matlab Linitis plastica. Very, very important. And the same thing, if you look at it under the microscope, it shows you the signet ring cells. What are signet ring cells? Ring jaisa lagega. So you will say, fine, over here I can see that the nucleus has come to the periphery. Why is the nucleus going to be present at the periphery? Because someone else is sitting. I can see something else sitting inside, and that something else is mucin. So please remember, you see the nucleus pushed at the periphery because the cells are filled with mucin, and that is why all of them are looking like rings, and that is known as the signet ring cell. That is diffuse gastric cancer. The next tumor that we take up is maltoma. Maltoma stomach kya hota hai? Maltoma is the other name for a marginal zone lymphoma. Margins of, that is how I had taught you in your theory, margins of age. Just before the puberty you will pick up, and just at adulthood, margins of age 11 and 18, translocation 11 and 18 is seen in marginal zone lymphoma. And lymphoma hai, तो lympho वाला कुछ lesion होगा. You microscopically you see LELs, lymphoepithelial lesion. Can you see? See, lympho ढूंढते हैं. These dot cells are lympho. Epithelium is these glands. So I can see these lymphoma cells. And the epithelium is nothing but the glands. And can I say the lymphoma cells are going and attacking the glands? They're trying to invade. So for example, if this is a gland, lymphoma cells are trying to go inside and destroy it, because lymphoma hai na, so it's a cancer. Cancer will always be deadly, right? LELs, lymphoepithelial lesion seen in maltoma. Maltoma is a marginal zone lymphoma, translocation 11-18. Now let's move on to esophagus ho gaya, stomach ho gaya. Let us move on to the intestine. The first disease of the intestine is a malabsorption, and that is known as the Whipple's disease, and of course we call it Whipple's because it is caused by Tropherema whipplei, which is a gram-positive organism, right? Now, if I see microscopically, I will see there are a lot of foam cells that are seen. Foam cells kya hai? Foam cells are nothing but macrophages. You'll say, "Arey ma'am, how do I know? You are a pathologist. You know they are macrophages. How do I know? Can you prove? Can you prove the nature?" Yes, I will put a stain, and ye wala line I tell students, mug it up as it is. Don't even change one alphabet of it. For the diagnosis of Whipple's disease, what is the cell that you will see? Macrophage. How will you see it? I will put a stain called PAS. P for PAS, P for pink. PAS always gives pink color. All these are pink color macrophages. Where are they seen? In which layer of the intestine? Lamina propria. So PAS positive macrophages in the lamina propria, classical for the diagnosis of Whipple's. This is done. Shall we move on to another malabsorption? Another malabsorption that we have is the famous celiac disease, the one that is related to gluten. I hope you all remember. I'm not writing it, but I know you all are aware. What are the cereals that have gluten? Barley, rye, oat, and wheat. These are the ones that are going to have gluten, right? So when gluten problem happens, look at this. This is the normal intestine. Guys, do you identify the normal structures? Look at this long finger-like projections that are going. Those are referred to as the villi. And look at these round structures that are going. Those are referred to as the crypt. So now I see that when gluten and antibodies will attack, villi will to flatten. The first thing that happens is villus atrophy. See, villi are gone. It's totally flat. So they will to flatten. Damage ho gaya. But these crypts, how can someone just come and destroy? I will compensate. So what do the crypts do? The crypts say that we will increase in number. We will fight back for you. We will fight back for the injustice done to the villi. So villi flatten and crypts emerge. So can I say that one thing is going to flatten, but other thing will make up for it? So one day you don't study, but next day you study double. So overall syllabus ho gaya na? So can I say the overall thickness is going to remain the same because one thing is flattened and the other thing comes up. Villi are flattened, crypt come up. And finally, they tend to show you intraepithelial lymphocytes, IELs. All these blue color dot that you're seeing, these are intraepithelial lymphocytes. Do you know what is this together known as in medicine? It's a very famous criteria called the Marsh criteria for the celiac disease, and that is a gluten related disorder. Which part of the intestine is most commonly affected? I hope you remember. The most commonly affected part is going to be the duodenum. Another malabsorption that we are coming to is the famous A-beta lipoproteinemia, only important for INI-CET. It is an MTTP defect. MTTP, if you want to know the full form, it's basically a triglyceride transfer protein. Problem kahan hai? Triglyceride transfer problem is there. Lipid problem is there. That is why all that you're seeing, the cells are becoming khali. Again, intestine. The cells are becoming khali. Why? Because there is a lipid accumulation that is happening. And not only that, I hope you remember what else does it show you. Guys, A for A, I always used to tell you, A-beta lipoproteinemia shows you A for acanthocytes. Remember, acanthocytes are also known as spiky spur cells. They are the cells which are RBCs which are going to show you spikes, and I can see lots of spiky cells coming up. So A-beta lipoproteinemia shows you A for A, and along with that it's an MTTP triglyceride ka problem. So all the triglyceride lipid accumulation will be seen. Again, this is for INI-CET. One more thing for INI-CET which is added in Robbins is MVID. That is microvillus inclusion disease. You can very well see that there is an inclusion. देखो microvilli तो surface पे होता है. Microvilli are on the surface. I am seeing microvilli inside. Microvillus inclusion disease. It's a genetic problem that happens because of MYO5B mutation. MYO5B mutation. तो microvillus है ना, microvillus. तो MYO5B mutation means the same. Clinical features, of course, there is intractable diarrhea that the child is going to have right after birth. And remember, there is going to be positivity for vilin protein and CD10 protein. Vilin and CD10 are going to be positive. Again, as I said, there is intractable diarrhea, which is microvillus से MY वाला mutation याद रहेगा. Villus से you will learn vilin is the protein. CD10 is how you have to learn extra. That is also positive. Now I move on to what other malabsorptions can occur. This is a previous year question. The very famous organism, Cryptosporidium. How do you identify? Cryptosporidium is present not inside the cells. It is stuck onto the cells. What do I say? It is present along the brush border. This line is very important. It never goes inside the cell. It's always going to get stuck onto the brush border. That is how you identify the cryptosporidium. How do you identify Giardia lamblia? Giardia lamblia will be girta hua, falling. Remember what motility? Falling leaf motility it shows you. So it is a girta hua man. Girta hua where? It is going to be seen lamblia in the lumen. Lamblia is going to always be seen floating in the lumen. Girta hua like a leaf, it's going to be floating in the lumen. It's a luminal organism. So now please note, what you're seeing over here is the duodenum sample. Either you can see it in the duodenum or you can see it in your stool sample. Stool sample might look something like this. Like an angry man wala face it looks like, hai na? But in intestine, it doesn't look like angry man. Inside the intestine, it starts looking like a sickle. So basically, I can say that when you're seeing it in the stool, you're seeing the front view. That is why it's angry man. In the duodenum, you see the side view. Side view makes it the sickle shape. Okay? So both the shapes are very well known. Both of them are for Giardia. In the exam, you will pick it up by its location in the lumen. Now let's go on to the next part of the intestine and what are the different ulcers. This is again pass-fail question in your second year also. So what are the famous ulcers, guys? First and foremost, you have TB versus typhoid. So one is transverse, one is longitudinal. See, one of them is transverse like this and one of them is longitudinal. So again, how do you wear a tie? A tie is always worn long. Tie is worn longitudinal. So typhoid ulcer is longitudinal and TB ulcer is going to be transverse. What is this ulcer? The amoebic ulcer. I can see a flask forming over here, right? So flask-shaped ulcers are very famously called as amoebic ulcers. Which amoeba? Entamoeba histolytica. Very, very important. Perfect. So the ulcers are done. Obviously, you know that when I'm talking about this, the next disease that I'll go on to will be the famous Crohn's and ulcerative colitis. Crohn's disease and ulcerative. So what are the set of images that you get over there? In Crohn's disease, I'll first start with the radiology sign, which shows you the famous barium study and the string sign. Crohn's disease shows you string sign. There's another thing with S that they always teach you. And they always say that there is an ASCA antibody that is going to be positive. It is ASCA positive. But what is the hallmark? And mug up this picture as it is. Ye hamesha puchenge. The hallmark is going to be the granuloma. How did I identify? The same picture will come in again and again. How did I know this is a granuloma? Because I could see a giant cell. Whenever I can see a giant cell, look at this. Whenever I can see a giant cell, I know it is a granuloma. So please remember the hallmark of this particular disease is a non-caseating granuloma in the intestine. Acha, why is this the intestine only at the first place? Could you see some cells which make it the intestine? Goblet cells, hai na? Tabhi first I thought intestine, then I saw granuloma. Crohn's disease comes to my mind, but how will the specimen look? C and C. If you look at the specimen from outside, it looks like a bag of fat. Creeping fat. A specimen from outside is going to look all yellow, that is creeping fat. Whereas specimen, if you open it and look at it from inside, it looks like these stones. That is known as the cobblestone appearance. So outside bag of fat, creeping fat, inside cobblestone. That is Crohn's disease. How do I compare it radiologically? Radiologically kya tha? It was showing you the string sign. But what are you going to see in ulcerative colitis? Ulcerative colitis shows you the intestine like this, like a strong lead pipe. Yes, ulcerative colitis shows you lead pipe appearance, and I hope you remember what was the antibody in it. It was P-ANCA positive. Everyone sorted with the disease. I'm not going into obviously all the details. I've done that in the RR. Right now I'm focusing more on the images part of it. Ho gaya. Now we're left with polyps. What are the first two polyps that I have to discuss with all of you? Hyperplastic polyp versus sessile serrated adenoma. Quick doubt hi nahi hai, ma'am. Why are you comparing these? Because hyperplastic polyp over here, if I see, it is non-cancerous. This is non-neoplastic. Sessile serrated adenoma is precancerous. That is why I am comparing it. But koi comparison hi nahi hai. One is innocent, one is very, very troublesome. So I have to differentiate. Now I have to tell the patient whether you have innocent wala polyp or you have deadly wala polyp. What is the problem? Why am I confused between them? This, if you look over here, if you look at the crypts on the bottom, round lag rahe hain na? They are round. But as you go up, are they looking all zigzag like this? Yes. So these are known as serrations. But I say serrations are only in the upper part of the polyp. That is a hyperplastic polyp. When serrations are only in the upper part of the polyp, that is hyperplastic polyp. But look at the next one. You are seeing some zigzag on the top, you are seeing it in the middle also, you are seeing it in the bottom also. So you will see when serrations are seen all throughout. Yahan par to can you see it's looking like a boot, it's looking like a shoe. When you see serrations all throughout, you will have to keep serrations in the name then, sessile serrated adenoma. So jiske naam mein serrations hai, that is going to show you serrations all throughout, and that is the one which is deadly, precancerous. So it's important that the pathologist, I have to see serrations are only seen in the upper part or are serrations seen everywhere, because upper part mein hai to innocent wala polyp hai, hyperplastic polyp, nothing to worry. But agar all of the part shows you serrations, it is SSA and that is precancerous. Sorted? The next one, if they give you a history, 5-year-old child with bleeding PR. 5-year-old child, matlab juvenile, bleeding PR means rectal polyp. And this question has come in NEET 2019, in FMG 2020 and in NEET 2023. So it's quite an important question. Sometimes image, sometimes theoretical. So they will always give you a 5-year-old child with bleeding PR, and can you see how is this polyp? Glands kaise hain? Chota glands or dilated glands? It shows you cystically dilated glands. It shows you cystically dilated glands. That is what is important. So what is the genetics? If you all remember, it is BMPR1, SMAD2, SMAD4. And you remember the trick of learning this? I told you age is also less than 5 and genetics ka numbers are also less than 5. Everything's going to be less than 5. That is juvenile rectal polyp. Versus if I show you everything being 11 means if the genetics is also STK11, if the genetics is STK11 or LKB1 gene, and they ask you what is the age of onset and you answer the age also as 11 years, you know the 11 one is Peutz-Jeghers polyp. STK11 and 11 years is the Peutz-Jeghers polyp. Break it na? Break it into Peutz and Jeghers. So P is telling me that these patients have pigmentation. I can see the pigmentation over here. P is also telling me that there is a polyp. Yes, what kind of a polyp? I can see an arborizing polyp or a Christmas tree polyp. Something like a tree is going to be seen. Tree is made up of what? Tree is always because of its branches, backbone. So they ask you, who is the backbone? Who is the branches? Please note it is the smooth muscle. The smooth muscle is going to make the backbone, or I'll write it as branch so that you remember. Okay? So this is the Christmas tree polyp. So as I said, P for pigmentation and P for polyp. But where are the polyps seen? JE for jejunum. The polyps are most commonly seen in the jejunum, and that completes your Peutz-Jeghers. Remember STK11, age also 11. I hope everyone is sorted with this. Peutz-Jeghers syndrome also done. The last 2-3 images of intestine that you're left with, it's actually a radiology image. Which of them shows you the apple core deformity? Of course, it is seen in intestinal cancer or colon cancer. I just wanted to quickly ask you what is the tumor marker, because that has started getting a lot of questions. So I hope you remember CEA, carcinoembryonic antigen, is the tumor marker. Coming to almost the end of the intestine, if they say there is a patient who's presenting with acute appendicitis, they don't expect you to analyze appendix from this. No, they just want to find out that when does a pathologist give the diagnosis of an acute appendicitis? Itis, matlab inflammation. Acute, what is the cell of acute inflammation? Neutrophils are the cells of acute inflammation. Where do you see the neutrophils? Which layer of the intestine should you see this? So remember, in the muscularis propria. When you will see neutrophils in the muscularis propria, that is when you give the diagnosis of acute appendicitis. Because I'm talking about the appendix, is there any worm in microbiology, parasitology that I say vermiform appendix mein jata hai? Enterobius vermicularis, of course. Enterobius vermicularis goes into the vermiform appendix, and if you remember, Enterobius vermicularis shows you D-shaped egg. D will remind you of this, plano-convex, and E will remind you of Enterobius. So plano-convex egg that you're seeing over here is of Enterobius. But this is egg, to kahan hoga? Egg will come out in the anal region, hai na? What is in the appendix? Appendix mein kya hota hai? Appendix mein you see the adult worm. How will you identify the adult worm? Enterobius ka worm sends out some little projections. Can you see one tiny projection here and one tiny projection here? Same way, can you see one tiny here and tiny here? So these are known as cuticular ala. To identify Enterobius, you're going to see cuticular ala. So now you can learn CDE. What is this CDE? CDE means that we are going to see cuticular ala and we are going to see the D-shaped eggs. That is what is going to make it Enterobius vermicularis. Sorted? That wraps up all of your GIT chapter also. So let's begin with the next chapter, and that is liver pathology, a set of quick questions and images which will take us not more than 10 minutes. So what you have in front of you is the very famous hepatic lobule, and the central part of it, as you all can visualize, is the famous central vein. What you have running outside from these pink colored cells are the hepatocytes. And of course, you can see these white spaces. Why are there spaces between hepatocytes? Because that is where all the blood supply comes from. That is the sinusoids. So we always say that there are cords of hepatocytes. There are going to be cords and cords of hepatocytes, and between them there are sinusoids. So if I show you a picture like this is one cord of hepatocyte, this is another cord of hepatocyte, and in between them I think everyone can visualize these are the sinusoids. But between the hepatocytes and the sinusoids, there is a space called the space of Deci. And why is it famous? Because the first place where amyloid deposits in the liver is the SOD, space of Deci. That is the first place where it deposits. And this space of Deci has a cell. Can you see a cell hiding here? That is Ito cell or stellate cell. See, Ito cell is the sleeping version of it. Stellate cell is the active version of it. Cell is the same. Ito cell is the cell which is going to store all the vitamin A for us. But when it becomes active, the active form is known as stellate cells, and that is going to lay down collagen type 1 and 3, resulting in cirrhosis of the liver. So these are the two things that you have to know. Ito cell is going to be sitting, eating and becoming fat, vitamin A. Whereas stellate is doing all the work and is going to lay down collagen 1 and 3 and cirrhosis of the liver. These are all previous year questions. Okay, let's move forward. The most famous thing that you have in the liver is this onion skin appearance, and that is known as primary sclerosing cholangitis, PSC. Primary sclerosing cholangitis has an antibody which I'm sure everyone is aware of, that is the P-ANCA antibody. And we also see that if this is the normal biliary tract, radiologically you will see there is pruning. What is pruning? Pruning basically means, for the trees we have, like you've seen this. For example, if these are the trees and how if they are cut, the branches are cut, that is pruning. So same way, if this was a biliary tree and now the branches seem to be cut, so that is pruning of the bile duct. And what do you see microscopically? The famous onion skin appearance. So the onion skinning of the bile duct is noted. Remember, these are all questions. Pruning, P-ANCA and onion skinning for primary sclerosing cholangitis. Let's move forward. Right now you were talking about cirrhosis, right? So how do you classify cirrhosis, or how many types of cirrhosis are there? We can see there is micronodular and macronodular. What's the cutoff? If the nodules are less than 3 mm, that is micronodular. If they are more than 3 mm, that is macronodular. So if you notice, chota, all this child, like Indian childhood cirrhosis, chota, child. So that is going to show you small nodules. Hemochromatosis, small nodules. So please remember, childhood has a C, so chota nodules. Hemochromatosis has a C, chota nodules. Whereas viral hepatitis and Wilson's, they are going to be very, very viral, very, very big. So viral hepatitis and Wilson's disease mein you're going to see very, very big nodules, macronodules. Okay? So chota wala are less than 3 mm and very, very big. Viral and Wilson are more than 3 mm. But alcoholic liver disease can show you both. Initially, it shows you micronodular cirrhosis. After some time, it shows you macronodular cirrhosis. So alcohol to dono type, right? Now, because we were talking about alcoholic liver disease, I'll show you all the pictures of alcoholic liver disease also. So a chairs that has been shown over here. When you're talking about alcoholic liver disease, of course, what is the first thing that happens? The first thing that happens is fatty liver. So fatty liver is how many types? Either you will see chota fat, you can see like hardly any tiny globules of fat, microvesicular, or you can see big fat spaces, that is going to be macrovesicular. So fatty liver is also of two types. Wo cirrhosis tha, that was cirrhosis, what you were seeing with your own eyes. With your own eyes you saw micronodular, macronodular. Now you're seeing under the microscope for fatty liver, microvesicular, macrovesicular. Mnemonic is the same. All the chota things, chota kids wala things will show you microvesicular. Means, for example, fatty liver of pregnancy say a kid is gonna come out. Ray's syndrome is what happens in kids. HELLP syndrome also occurs very commonly in pregnancy, from which a kid comes out. So anything related to kids is going to show you microvesicular fatty liver. And all the other things related to nutrition, like we have obesity or diabetes, parenteral nutrition, starvation, so any metabolism or any kind of nutrition problem, and hepatitis C, they tend to show you macrovesicular. So where is alcohol? Alcohol as usual, alcohol everything. Alcoholic liver disease shows you microvesicular and macrovesicular fatty liver. Okay, let's consider a case of alcohol. Alcohol में पहले छोटा छोटा vesicles था, then big vesicles. So fatty liver तो I have seen. What after that? After that, in alcoholic liver disease, you start seeing the presence of Mallory-Denk bodies or Mallory-Hyaline bodies. So if you notice these very pink bodies over here, those are the Mallory-Hyaline or the Mallory-Denk bodies, and what are they made up of? Cytokeratin 8 and 18, previous year question. But are they only seen in the alcoholic liver disease? No. There is a mnemonic for Mallory-Hyaline bodies known as New Indian Watch. New matlab non-alcoholic and alcoholic liver disease both show Mallory-Denk bodies. New Indian, Indian for Indian childhood cirrhosis. Watch, W for Wilson's, A for alpha-1 antitrypsin deficiency, T for the tumors, liver tumors, C for cholestasis, and H is going to be for hepatic or biliary diseases. So this is going to be the New Indian Watch, which is going to show you the Mallory-Hyaline or Mallory-Denk bodies. I hope you remember this mnemonic from your RR and main videos also. So firstly, when alcohol consumption happened, तो ऐसा fatty liver हुआ. After that, these Mallory-Hyaline or Mallory-Denk bodies started forming, and after that, one more thing happens along with this. Alcoholic liver disease shows you chicken wire fibrosis. देखो जैसा chicken wire होता है ना, like a wire. Similarly, you're gonna see these blue color. Can you see around the cells there is a chicken wire fibrosis that is also noted. Okay, after this what will happen? After this तो nothing can happen. After this patient is going to go into cirrhosis, micronodular छोटा nodules, then big nodules, and then finally death. You've seen the sequelae, fatty liver with Mallory-Denk bodies, chicken wire fibrosis, and cirrhosis. Okay, this is all alcohol related. There is another type of cirrhosis known as biliary cirrhosis, which can actually tell you it is related to bile. Bile matlab there's gonna be a green color. देखो cirrhosis तो है. I can see nodule, but it's all green in color because it's biliary cirrhosis. There is something different. Here also I can see nodules, but those nodules are a little different, as if they are jigsaw puzzle pieces trying to fit into each other. It shows you the jigsaw puzzle nodule, and because it has so much of bile, it's gonna show you lots and lots of bile plugs. ये golden color का lots and lots of biles it will show you, and they will ask you what is the stain for bile. It is the Hall stain for bile that you have to know. So repeating, if there's biliary cirrhosis, bile duct से related, तो green color होगा, jigsaw puzzle pattern होगा, and lots of bile which is stained with the Hall stain. This is one type of cirrhosis. Let's move forward. There is another type of condition which is only important if you're targeting INI-CET, and that is autoimmune hepatitis. Autoimmune, some antibodies are creating it. So 3 pictures come in autoimmune hepatitis. One of them is interface hepatitis. Interface means दो चीजों का interface. If these are hepatocytes, this is portal tract. So for example, till here it was hepatocytes, and from here it was portal tract. So can you see at the junction you're seeing a lot of blue color cells, lymphocytes. Interface is having inflammation. So autoimmune hepatitis shows you interface hepatitis between hepatocytes and portal triad. Then I've already taught you in the second chapter images emperipolesis, cell in cell. Did I teach you that the mnemonic mark? Mark shows you emperipolesis, and in that I told you autoimmune hepatitis shows you emperipolesis. There's a big cell which has eaten a tiny little cell. Yes, cell in cell appearance. Okay. Another thing that you see in autoimmune hepatitis is hepatic rosettes. Rosettes matlab round like rose petal. I can see the hepatocytes are arranged round. Till now, the first image I showed you was hepatocytes were arranged in cords. I always used to say hepatocyte is one cord and one cord. Now I'm saying hepatocyte has been put up into a rose. It has been put up into round. So that is known as a hepatic rosette. Okay, so completing, autoimmune hepatitis shows you interface hepatitis, shows you emperipolesis, shows you hepatic rosette. Sorted. What is the next disease? Because we're talking about hepatitis, how can we miss out on viral hepatitis? What are the bodies that you see with viral hepatitis? These are the very famous Councilman bodies. Councilman bodies are nothing but, go back to the first chapter. Councilman bodies are apoptotic bodies. You can see these highly pink color bodies are the apoptotic bodies. But which viral hepatitis are they very commonly seen with? So Councilman hepatitis C. It is going to be seen very commonly with HBC. Hepatitis C के साथ common होता है. That is Councilman body. If I ask you the next, which hepatitis shows you ground glass hepatocytes? Ground glass means, can you see? It's homogeneously pink, all glassy, washed out kind of pink, like ground glass, very commonly seen with hepatitis B. Can you guess the next hepatitis? The hepatitis which shows you, number one, it's showing you a lot of blue cells, which is lymphocytes. Number two, it is also showing you fatty liver. It is showing you fatty change. So which is that hepatitis? Go back. Did I just tell you one hepatitis shows you macrovesicular fatty liver? And that is hepatitis C. So remember, hepatitis C shows you fatty change along with lymphocytes. So learn these three. Councilman bodies are also seen, can be seen with any viral hepatitis, but more commonly seen with C for C, hepatitis C. Plus hepatitis C shows you this fatty liver and lymphocytic aggregates, and hepatitis B very commonly tends to show you the ground glass hepatocytes. Well, on that note, the last image that you have to know in liver is the very famous alpha-1 antitrypsin deficiency. Firstly, the chromosome for it is an all-time favorite question. Alpha-1 antitrypsin gene is on chromosome 14, and the two organs that are affected in this alpha-1 antitrypsin deficiency are L and L. The liver that I'm teaching you right now is going to show you the presence of cirrhosis, and lungs, if you go to the chapter, I have already taught you even in this image section that it shows you pan-acinar emphysema, right? So that is easily settled for all of us. However, I'm going to see it, this picture comes as it is in the paper. Can you see these pink granules? Yes, you see PAS positive diastase resistant lesions or granules or inclusions noted. Repeating, PAS positive diastase resistant. This is going to be like 100 star if I can mark it. Remember, chromosome 14 for alpha-1 antitrypsin deficiency, L and L, lung and liver, and it is PAS positive diastase resistant, pink color. This is a must know for the exam.